All right, welcome everyone to the fourth annual Sickle Cell Summit with a theme this year of preventive care and management, building a medical neighborhood. The summit is being organized by our advisors. And before we get started, I just wanted to have a few, to make a little disclaimer. First of all, to thank you for your interest and participation, and to remind everyone that the summit is intended for educational purposes, you shouldn't any medical related questions should really be directed to your healthcare professional. Also, the summit is being recorded and may be posted on social media. Just a few housekeeping details. If you're not, please keep yourself muted unless you're asked to unmute yourself. The features at the bottom of your panel, there is a chat feature, a raise hands feature, and a question and answer feature. The chat feature we'd ask you to use to share resources, but if you have questions during any of the presentations, to type them into the Q&A box. And if you have a question, you can raise your hand and alert us that you're typing a question into the box. So if there's nothing, without further ado, I'd like to introduce our moderator for the day, Dorinda Sims Lawrence. And she will be leading us through the day today. Dorinda?
Good morning, everyone. As you said, I'm the moderator. I am an advisor with ISAC, and we're going to go ahead and move on toward the summit. I'm going to introduce to you our speaker for today, which is Dr. Victor Gordu. He's our corresponding PI for ISAC from UI Health, the director of the Sickle Cell Clinic. We're going to pass it on to him.
Okay, thank you, Ms. Lawrence. And thank you, Judy Nosek, for the introduction. We're very happy to welcome you all to the fourth annual Sickle Cell Summit. The Sickle Cell Summit is held as a part of the Sickle Cell Disease Implementation Consortium's Chicago site. The SCIDIC Consortium is a nationwide program funded by the National Institutes of Health that includes 8 clinical sites nationwide. Chicago is one of these sites, and we are sponsoring this Sickle Cell Summit. We call our site ISAC, and that refers to improving sickle cell care in adolescents and adults in Chicago. And that is the focus of our overall program, and that is the focus of this summit. Could I have the next slide, please? So the general aims of the ISAC study are to help patients with sickle cell disease access longitudinal care consistently, to increase the number of patients taking hydroxyurea and the number of providers who prescribe this treatment, and to provide proper management of pain in the emergency department. These were the goals we set up when we first applied for this program back in 2015. Next slide, please. And now that we have been a part of this program for 6 years, these are some of the successes that we have had. We have a registry that includes 308 patients 15 to 45 years of age here in the Chicago area, and it makes up a part of a registry of 2,400 patients nationwide. In terms of implementation research, we have an active care redesign protocol that helps providers and patients use apps to optimize hydroxyurea therapy. We have an ED care protocol that develops a pain passport or an individualized pain plan for helping patients to achieve appropriate treatment of acute pain episodes in the emergency room. And we also have a program to help unaffiliated patients begin to receive high quality longitudinal care. And this part of Isaac has led to the topic of the present Sickle Cell Summit, Preventive Care and Management in a Medical Neighborhood. Now, another feature of our program that we're very proud of is the annual Sickle Cell Summit. And this is a unique program and conference nationwide, I believe, because it is organized by patients or persons living with sickle cell disease in the Chicago, Illinois area. And these patients are our colleagues and co-workers in the Isaac program. And they have developed this summit based on the perceived needs of persons living with sickle cell disease and their families. So we're very proud of this summit and those who have prepared it. Next slide, please. And this shows the collaborating institutions and health professionals in the Isaac program here in the Chicago, Illinois area. It includes the University of Illinois at Chicago with a team of principal investigators, as mentioned here. It includes the Sinai Health System, Mount Sinai Hospital with Dr. Verda, and Holy Cross Hospital with Dr. Pandit. It includes Wandersman Associates in South Carolina. It includes Lawndale Christian Health Center and Dr. Eugenia Sanders there. And they're helping us out a lot in this Sickle Cell Summit. It includes Dr. Saving and the University of Illinois at Peoria. And it includes our Community Advisory Board, made up of persons living with sickle cell disease and their family members. And again, we'd like to express our gratitude for working so hard to develop this summit. Next slide, please. And again, here we are, 2021 Chicago Sickle Cell Summit, Preventive Care and Management. And again, the persons who have helped develop this, who actually have developed the program for this conference. Thank you so much again. Next slide, please. We'd like to move on to the keynote speaker for the 2021 Sickle Cell Summit. And this is Dr. Julie Cantor from the University of Alabama at Birmingham. She's Associate Professor of Hematology Oncology there, and she's the co-director of the Comprehensive Sickle Cell Disease Program at UAB and the director of the Adult Sickle Cell Clinic. And I must say that she is really an international expert in sickle cell disease research and in promoting for the actual implementation of programs that help persons with sickle cell disease receive the care that they need. We're very proud that Julie could join us. Welcome, and we're eager to hear what you have to share with us.
Thank you, and thank you very much for that really kind introduction. I'm super excited to be with you today. I'm only disappointed not to be with you in person, where we could have maybe enjoyed some Chicago pizza or other finery. So hoping in the future we can make that happen in person. I'm going to go ahead and share my screen. And I also wanted to really get the chance to wish everybody a very happy Sickle Cell Awareness Month. It is the last day of September, so we don't want to forget that it is the most exciting month of the year if you are us. And so that makes it even more special to be here today with you all. So I'm going to talk about what is a medical neighborhood and why do I need to see a specialist? And I think it ties in really well to what Isaac is doing and what we are doing as the Sickle Cell Disease Implementation Center Consortium as a whole. These are my disclosures and they're not really relevant to this discussion. I want to really look at sickle cell disease as a chronic disease and talk about how we manage a chronic disease. And I think this is so important because we spent many years thinking of sickle cell, of all the acute things that can happen, but sometimes forgetting to manage the whole person, the whole life. Evaluating how we can successfully treat sickle cell disease by looking at another disease that's done a great job. How do we apply what they've done to sickle cell? Explain what defines a sickle cell center And then I'm going to introduce a new network of centers that I hope will increase access to care. So I don't need to tell this audience that sickle cell disease is a rare disease that continues to significantly limit life expectancy. And that's due to chronic complications, despite really significant improvements in childhood survival and increasing availability of therapies. So we know that many individuals have very complex healthcare needs, and they only get more complex as they grow older, because unfortunately, all of our body starts to wear and tear as we get older. And healthcare providers with these disease-specific knowledge are really critical to improve and help prevent complications. Often we have found, and I think you all know this incredibly well in Chicago, that it's very individualized based on where you live. And some of the healthcare opportunities, such as Medicaid and Medicaid expansion, are very state-based, but some of it is even more local than that. It may be zip code-based. And a lot of people have insurance, but it doesn't mean they have access to necessary, appropriate care. And sometimes that care really equilibrates to who you know, who's the best advocate, or who has the most knowledge to get you to the best place. So we have to really shift how we are looking at this disease to build a better system of care to enhance access for all individuals living with sickle cell disease and really improve coordination. And we want to make sure that all of our affected individuals get true comprehensive care. So I love this figure. I show this figure a lot when I talk because I think it's so important to recognize that sickle cell is such a multi-system disease. I think when you think about sickle cell disease as a simple blood disorder, that really doesn't give the breadth of the complications that can occur. And if you think of it more broadly as our entire body needs blood to function appropriately, then it makes sense that all organs of the body can be affected by sickle cell. And what we need to do and continue to learn to do better than we have thus far is prevent all of these complications. Right now, I think we're at a stage where we can recognize them, but we can only prevent some of them, and we're still learning how to prevent the majority. So why is this so important, right? Haven't we made this so much better in childhood? And we have, and this is now getting to be an old graph, hope to have a new one soon. But it shows us that while our childhood survival is remarkably improved, you can see these curves down here from 1979, where a lot of children died. We are now having the majority, about 96 to 98% are living into adulthood, but we're still seeing this huge peak in early mortality that's truly unacceptable. And our most recent surveillance data suggested a mean age of death at 43 for women and 41 for men. So we know that sickle cell disease is a complicated, chronic, and complex disease. And that means it involves multiple medical morbidities that require the attention of multiple healthcare providers and facilities, and also the community and home-based care. And so we know our individuals affected with this disease have complex health needs that requires both medical and social services, and really a wide range of support systems in place. And this type of individual really continues to present a difficult enigma to our healthcare system. The United States continues to fail in our ability to keep people healthy compared to other countries. And it's unfortunately and truly remarkable that we are still a reactionary society. We're really good at reacting to problems, but we're still not great at preventing them. And that's especially true for individuals with a chronic disease, and for a chronic disease that starts in childhood and goes into adulthood. So we know that our affected individuals have truly unique needs and disabilities and sometimes functional limitations. So we have to think about this from a systems level. We have to build a system so that we can implement care in a better way. There's still a zillion things we don't know about sickle cell disease. I get asked all the time by our residents, why do you do this? And this could be anything. Why do you use this pain regimen? Why do you choose, this amount of medication? Well, we have a lot of things that still are not true standard of care. They're standards of care that we've adopted, but we need to prove them on a population level. So there's this broad variation in practice where anecdote and opinion have become translated as data, and we need to do better than that. And with the data that we do have, and there is some amazing data, we know that Sickle Stroke Screen or TCD can identify the risk of stroke in young children with sickle cell disease, but we're still not implementing it sufficiently. So there's this huge gap between what we know and how we practice it. And then there's these historical, professional, and political boundaries and minimal funding that has caused a lot of fractions within our community that we have to improve. So how do we get better then? What's the pathway to getting better? Well, we know that our research of new drugs and therapies is amazing and very important, but we don't want to continue to do research on new therapies while we're not ensuring that the patients that we are taking care of are getting the appropriate care that they need. And so we want to ensure that all individuals have access to a sickle cell disease specialist, and that truly has to be a primary goal. And we have to really validate practices and standard of care. And then from the provider side, we have to figure out how we appropriately are reimbursed for the care, because we all want to provide multi-specialty, multi-centered care where we can ensure all of our affected individuals have access to a psychologist and a social worker and all the individuals within our team that sometimes, unfortunately, our system doesn't pay for. So our outcomes have to be the result of a system of care, and we have to work together to get there. So when you look at how our system is set up to treat a chronic complicated disease, one of the mechanisms that was put in place not long ago was what is called a patient-centered medical home. And this offers a model for providing comprehensive coordinated primary care that is supposed to be very patient-centered and accessible. And so we have to look at this as to what they kind of think a PCMH is. And this is just one example, right? So the patient is at the center of all of these different individuals who in some way help manage their care. And what I want to call the attention to here is you only see one red specialty physician, right? And that's not accurate, right? Our patients have a lot more than one specialty they may need to see. They may need to see the sickle cell specialist, but then what about a neurologist or an orthopedist? So this leaves a little bit to be desired. And they are really designed, these PCMHs were designed to fit adults and now some children, but they're designed to fit your everyday average individual. And that's really different than a chronic lifelong health condition. They're pretty decent for heart failure and diabetes, and so it's sort of common primary care chronic diseases, but not specialty chronic diseases. So what is not treated by a PCMH? Well, these chronic complex diseases that need specialty care. So inherited metabolic conditions, cystic fibrosis, cancer, hemophilia. You've never heard someone that might live in rural Arkansas who's diagnosed with breast cancer, and the primary care doctor says, well, I don't know any oncologists, I'm just going to give you chemotherapy. That wouldn't happen. And so we shouldn't say that about individuals living with sickle cell disease. You live in rural Arkansas, so you don't get to see a specialist. So we have to rearrange our way of doing things to fit our patients who are affected. So what is a medical neighborhood then? So the concept of a medical neighborhood refers to the many services and professionals that are needed to support the health and well-being of patients. And the medical neighborhood takes into account more specialties that may be needed, not just that primary care and maybe one specialty. And it takes on the responsibility of the patient from a coordinated care standpoint. So this concept of the medical neighborhood acknowledges that sometimes the medical home isn't enough and can't serve what the patient needs and desires. So we have to expand and form sort of a neighborhood. So that ideally will include every caregiver interacting with that patient. But as you of course know, right, as individuals have more and more people helping manage their care, sometimes that increases the potential for breakdown in communication and coordination. And this loss of care coordination can obviously negatively impact individuals, right? Confusion, who do I go to? And we get this all the time. You know, in our sickle cell center, someone will call me and they have a sore throat. That's something they can certainly see their primary care doctor about. Well, what if they have a cough? Is that a primary care issue? Is that a sickle cell issue? Is it a pulmonary issue? Sometimes it results in duplication of services. I have patients who've gotten 3 echocardiograms in 3 different hospitals, one because their renal doctor was in one place and their cardiologist was in the second place, and I, the sickle cell doctor, was in the third place. And we weren't talking to each other. And so that can be unnecessary, it can be expensive. And then sometimes if, for example, I'm not talking to a nephrologist, I might do a procedure that could hurt a patient because I don't know what the nephrologist has told that person. So at worst, it's harm. So the goal of a medical neighborhood is to ensure that individuals get the care they need from the right people within a system designed to ensure seamless communication and coordination. And at the center of the medical neighborhood is still the primary care doctor. It's not really the patient at the center, but it's the primary care doctor who's coordinating all of these specialties for the patient. So this is just an example, right? This is Chiquita. She's a 49-year-old with SS disease who is sort of a typical individual in my clinic who may have chronic kidney disease and pulmonary hypertension, but she's also gone through some menopause and also has some chronic pain. So she needs all of these specialists involved, and each of them has something important to add. And at the same time, each of them needs to talk to each other to make sure that we're not duplicating efforts, or that, for example, the GYN, the gynecologist, isn't trying to treat her menopause with estrogen, which I, the sickle cell specialist, know could cause her to have an increase in blood clots. So how do we ensure that there's this kind of communication in the medical neighborhood? So this was one of the better images that I could find. And here we have a patient-centered specialist, which is essentially a coordinator. A patient care coordinator could be a navigator, it can be a community health worker. And that's the person who should really be helping to manage all of these different things that are ongoing. And what I like about this slide is it really shows just how busy a complicated medical care system can be. It also can show that maybe the systems of care don't talk to each other. So we have these great EMR systems, electronic medical health record systems, except they don't talk to each other at all. And so even, for example, in my clinic, our EMR called Cerner doesn't talk to the EHR that our retinopathy specialist uses. So I can't see the notes from our patients' eye doctors, and they can't see my notes, which amazes me in this day and age that we're not better than that. So while this may work in a system that's really well organized and can share medical records, even for a patient coordinator, it can be difficult if they can't see the different things from the different clinics. So how do we then keep this medical neighborhood from becoming a too many cooks in the kitchen sort of circumstance? This is an image from Top Chef where they're always, fighting and stepping on each other. So we need to look at other complicated chronic and complex diseases that require a specialist and perhaps take some clues from them. And I've spent the last year really focused on understanding how cystic fibrosis has gotten to be such a model of chronic disease treatment, and understanding what's out there that I need to understand to make sickle cell like cystic fibrosis. So it's a lifespan condition, it's very similar, and they really use this fantastic coordinated care model. It's a lifelong disease. Complications get worse with age. Individuals require very disease-specific but highly coordinated care. And we had a talk recently about the Cystic Fibrosis Foundation, and what they really told us, what we learned from cystic fibrosis, is that they changed outcomes using center-based care. So instead of, the medical neighborhood per se, with a primary care doctor in the middle, they had the cystic fibrosis center in the middle. But they had to define what a center meant. And that was important so that when we look at different centers, for example, if I want to know how the University of Illinois at Chicago is treating kidney disease, and I want to compare that to how I'm treating kidney disease in our sickle cell patients, then we have to be playing on the same ball field. So they had to define what is a center, who is on the ball field, who has a ball field. And then the centers have to agree to collaborate. And in sickle cell disease, we just haven't done the best job of collaborating. It's something that we have to do better. And a lot of that is financial, and that we just haven't had the funds. And so each center kind of does its own thing. And they all had to agree to use the same registry. And this was super important because it was the only way that we could really measure care across systems. And if we're going to make changes for the better, then we have to measure things the same way so that we can then measure outcomes. So they put together a registry together. They used very focused, coordinated efforts to target improvements through both philanthropy and drug development. And they did this as a whole group, as opposed to several different groups working to raise funds. And then they ensured funding to each and every center for data entry to improve quality improvement. Because again, without data, we can't make the differences that we want to make in our patients' lives. They also invested in funding for therapeutic development that takes someone who's far more business oriented than I to understand, but they have done an amazing job with this. So then we need to model this. We need to model a successful system to approach lifespan chronic, like another lifespan chronic condition, so we can improve our outcomes in sickle cell. So then what does that really mean? We need the same attention to disease-specific, highly coordinated care. So as we looked at in the very beginning, sickle cell can affect every organ system. So then the sickle cell center should be in the middle of that coordination for someone who's affected by the disease. We should be more responsible for coordinating patients' care, ensuring they get to the specialists they need. And then we have to cooperate as sickle cell centers to collect longitudinal data to really understand what our impact is and how we make a difference, and then to change it, to recognize, you know what, gosh, UAB is not, we are not doing a good enough job. It's doing our renal screening, looking for sickle kidney or sickle nephropathy. So what is University of Illinois doing that we're not doing, and how can we implement that? And that's what we call quality improvement. That's how we truly provide better quality care for patients. And so we said, okay, we have to work together. We have to be an alliance of sickle cell centers to achieve these goals. And then we need to get some money, right? We need to go get some dedicated funding, because our population has truly suffered more health disparities compared to those with CF or hemophilia or other genetic diseases combined. And then we need to take the show on the road, because while we need to really improve our outcomes in the United States, just think about the number of affected individuals in India or sub-Saharan Africa. So how do we sort of form these care models, and then how do we take those to the places where the population's much larger? So we faced all these system level barriers for a while. We've had a lack of coordinated network of centers. We've had a lack of a clinical longitudinal data registry. We've had a lack of centers in general, just not enough funding. And when you compare that to, again, cystic fibrosis and hemophilia, where there are combined less individuals affected by hemophilia and CF in the United States compared to cystic fibrosis. And there are 141 federally funded hemophilia centers and 280 federally funded cystic fibrosis centers. And so we need to call attention to this. We need to start, banging pots and pans and saying, hey, we need the same equal ethical funding as everyone else. So to do that, we also need to have definitions of who we are, what's a sickle cell center, so that we can get the funding we need, so that as these new medications come out, we get them to the people who desperately need them. So as part of the same project that ISAC is in, the Sickle Cell Disease Implementation Specialist, we had to start from the beginning. Before we could even define a sickle cell center, we had to define what is a sickle cell specialist. So we put together a Delphi study. That's a consensus study. That's asking a lot of people who we consider specialists in some way to provide their opinions, and then essentially slowly getting them all to agree. And this is who we had in our group. We had 65% sickle cell disease focused researchers. We had providers. We had people who worked on care guidelines. And then we had a lot of people who really focused in sickle cell disease. And together, these individuals defined a specialist by these criteria. They had to know the guidelines. They had to be trained in hydroxyurea and transfusion management. They had to understand and know how to screen for organ damage. They had to be aware of the psychological and cognitive issues in sickle cell. They had to have experience working with individuals with sickle cell. They had to have received training in pain management and sickle cell disease emergencies. They had to have been mentored by someone else who knew how to do this. They couldn't have just read a book. They had to attend conferences to get the newest information. And they really had to keep up that information, right? Because what we learned about 20 years ago in sickle cell disease, the world has changed. So then we had to figure out how that sickle cell specialist fits in with a sickle cell center. And we did another Delphi study, right? It worked really well. Let's do another one. So we asked a lot of groups, what do you need to be a sickle cell disease center, in the same way? This was in advance of a workshop in 2019. And it was an open-ended qualitative survey, and it was done mostly through email. It was a convenient sample of 14 centers and included centers in the UK. And it was required that they defined what a center is. And that also meant who their center was. Who did they see? How many patients? What was their staffing, their clinic structure? And then we defined what is required to be a sickle cell center. In other words, if you want to hang your shingle up and say, yes, we are a sickle cell center, this is what you have to have. And then we said, okay, these are the optimal things that we think that really you should have if we all had enough funding for them. And then we had some suggested individuals who could be involved, but maybe they weren't required. And this is really what we came up with, that we had to have a sickle cell specialist in the lead. We had to have a social worker, a patient coordinator, as you saw how important that care coordination is, dedicated, educated nursing staff. If your center was large enough, you needed to have advanced practice providers. You had to have the availability to create pain management plans for patients. You had to be able to do transfusions and apheresis. And then you had to have a timely access to support and specialty services. So you didn't have to have a gynecologist in your center, but you had to make sure you could get a patient to a gynecologist if they needed one and be able to communicate with that gynecologist. Most importantly, it had to be a thoughtful, very team-based approach to individuals living with sickle cell. It has to be consistent and comprehensive and coordinated throughout the medical environment. So again, that means whether that patient is seeing someone in GYN or kidney, that they are within the same medical environment and all that information is getting back to us at the Sickle Cell Center. And they had to be really programmatically tuned into sickle cell disease, and they had to coordinate care. And we also know that not all centers are the same, because whether you're in Chicago and you're going to treat a lot of individuals who are living in a city versus where I live, and you may treat a lot of individuals who live all over the state. So we're going to do this in different ways. Excuse me. They also had to make sure that they provided all access to all disease modifying therapies, to sickle cell disease prevention, to consultants. They had to be able to provide iron chelation, blood transfusion management, pain management, family planning, and have a mental health plan. And then we defined different models, because not everyone's going to fit this, or there may be a new program that's developing, but they're not quite a full center. And so we wanted to call them something. So we call them an associate center. They might be a center in development, and they might be somebody that's just associated with another sickle cell center, but they're never going to be a full sickle cell center. So then we term something called an affiliate. And this is like a hub and spoke model, where the affiliate is the spoke of the center. So maybe you're in Chicago and your spoke is in, a more rural area of Illinois. And what you do is allow that affiliate to use all of the specialists or the support system of the hub, and the patient still gets the benefit of that sickle cell center. They still get that access to the sickle cell specialist. And what we haven't figured out yet are how we're going to connect our community hem-onc programs who are also treating individuals. But the bottom line was this compassionate, comprehensive care that's highly coordinated to ensure continuous and personalized care, attention to the physical and emotional well-being of the individual. And what we need to do long-term is make it standardized and equitable so that you can get the right care regardless of which zip code you live in, and ensure that our vulnerable patient population gets equitable patient care compared to anyone with breast cancer or hemophilia or other chronic conditions. We also are requiring that individuals have data collection programs, because we want to track and improve outcomes. When you really look at certain things, it can be quite startling. The well-known study that Dr. Stu is part of is called Displace, and we've been looking at who's getting their sickle stroke screens, their TCDs, in a timely manner. And there was huge variability between sickle cell centers. In some centers, 35% of patients were getting what they needed when they were supposed to get it. And in others, 75% were getting their sickle stroke screens on time. So what is one center doing that the other center's not, and how can they learn from them? And so this center-based care can provide that learning health community to assure quality assurance to patients. So from there, we have launched what we call the National Alliance of Sickle Cell Centers. The Alliance was founded truly by concerned physicians who we just wanted to make care better, and we wanted to make care better long-term for individuals. So it's to support these sickle cell centers to deliver high-quality comprehensive care by setting standards of care, promoting those adoptions, identifying opportunities and resources to strengthen centers, build new centers, and truly advocate for all individuals to get necessary access to comprehensive care, so that we can make long-term differences in quality of life and survival. As we built the Alliance, we assured that there was collaboration between centers to collect data, to develop treatment guidelines, to integrate within the community, to have a community advisory board, as well as a community engagement process, to have a plan for comparative quality assessment and improvement. So our long-term goals are to create this infrastructure for adult and pediatric centers to define, continually enhance, and promote the adoptions of standards of care, so that, again, patients, wherever they're located, individuals living with sickle cell disease, can get access to appropriate care, to have tools that we can share to help others build sickle cell disease centers. We're using a registry called Granddad. We're making it into a national registry for sickle cell disease. And because the sickle cell disease implementation centers already have their own registry, we're going to crosstalk these registries so that they can talk to each other. We didn't use the SCDIC registry long-term for the Alliance because it's not sure to be continued by the NIH forever, and because it didn't ask the same types of questions. And so we decided to use Granddad, but we're going to crosstalk the two of them. And then we're working to identify more resources and create truly a sustainable existence in working with all of our other partners. So we think there's unbelievable systems levels possibilities here. Demonstrating that recognized centers can improve outcomes should mean we can enhance reimbursement. Why do we need reimbursement? So that we can provide better care for our patients. We want a new payment model. How do we ensure that our patients can get all of the aspects of comprehensive care they need? And by golly, one of these days it's going to include dental care. How do we enhance models of sickle cell centers to increase access to care? How do we involve telemedicine in the best way possible? And how can we bring in these affiliates that are in more rural areas, but also assure that those individuals get the appropriate sickle cell specialist care? So we have a lot going that we're super excited about. Hopefully you see how we have discussed some of the barriers to the traditional medical neighborhood, how understanding what a sickle cell specialist is has led to creating a sickle cell center, looking at cystic fibrosis as a truly successful model where they've improved outcomes, had new medications on a much greater level than we have. And it's something that we need to do, and then figure out how we apply that to sickle cell disease and hopefully moving the National Alliance of Sickle Cell Centers forward. And I'm hoping that this excites you guys. Obviously, it's something I'm quite passionate about because we really believe this is how we need to improve our outcomes long term. And that's it. And I have a zillion people to thank, the SCDIC included. Everybody has played a role in moving this concept forward. And happy to take any questions.
Do we have any questions for Dr. Cantor?
It's never good. I stunned everybody into silence.
We don't have any questions?
Oh, this is Dr. Gorduke. Julie, thank you for that presentation. That was really good. And the idea of a alliance of sickle cell centers to replicate success in other diseases is really a cool idea. Have you been able to succeed to attract any funding for the alliance of sickle cell centers?
We have. I'm glad you've asked. So we've mostly started with going after pharmaceutical funding. It was the easiest starting place. And what we needed was somewhere other than my pocketbook to start, because we also started with my pocketbook. And it allowed us to get some money in the bank so that we can look at other developmental opportunities. And I think what is appealing to these industries is the ability to collect and create a true sort of standard of care, as well as a lifelong continuing registry. That's what excites them. So that's where we started with funding, and we've gotten a lot of interest. So we're hoping to be able to really move that forward, but also looking at other opportunities. And we're, long term, we're really fighting for 340B. We really believe that that is one way that we could get the sustainable funding through a process of quality improvement. And one of the reasons we actually created the Alliance was specifically for 340B. So for those who don't know, 340B is a program by which hospitals who treat populations of individuals with either Medicaid, Medicare, or just uninsured populations can get access to medications at a cheaper amount, and then sell them back to insurance companies at the cost. So what it means is they make money on meds, essentially. And what hemophilia did in a while back was, for factor, which is very expensive, they have made it so that by having a structure in place in which the centers are accredited and undergo ongoing quality improvement, all of the money that comes to them by 340B can be reinvested specifically in their center. And it can be a really impressive amount of funding, and it has allowed for them to get the multi-specialty care that they need continuously, and to ensure that everybody has access to factor, whether individuals are insured or not insured. So that's what we're hoping to replicate. And to do some of that, we had to put a center structure in place.
Okay, well, that sounds encouraging that
Thank
you
you.
have an approach going there for that purpose.
Thank you,
I
Dr.
think
Canty.
that Ms. Lawrence, I think I'm gonna let you move ahead now so we can keep on schedule on the conference.
Well, thank you again for having me. I certainly appreciate it. And I hope everybody has a wonderful rest of Sickle Cell Awareness Month, and talk to you soon.
Yes,
Dr.
thank you.
Canty, thank you for sharing and explaining the importance of having and seeing a specialist, especially a sickle cell specialist. Thank you so much for sharing that. And what is a medical neighborhood? And what is a sickle cell center and the sickle cell models? Thank you so much. We appreciate it. Very informative. Excellent. Now I'm going to introduce you guys, Maxine Banks. She's going to take a moment to do an exercise break.
Hello, everyone. It's get up and move time. Hopefully you can hear me. It's get up and move time. So we've been sitting there for a few minutes. So what we're going to do, because we've been looking down at our screen, we're going to stretch out our neck muscles, okay? So we're going to do two sets of six. So follow along with me. What we're going to do is roll our shoulders first, all right? So you feel that stretch? Because we've been looking down at our screen. That's number 3. That's number 4. Good stretch. That's number 5. And we're one more. Number 6. So what we're going to do now is stretch out our neck. So we're going to do some chin ups and chin downs. We're going to do 2 sets of 5, chin up and chin down. And what I mean by that is up. That's 2. That's 3. We're stretching out our neck. That's a 4. Keep going. That's a 5. That's a good stretch. That's 6. Chin up. That's a good stretch. So we're going to go down now. That's a nice stretch. That's 2. That's 3. That's chin down. That's 4. Good stretch. Chin down. That's 5. That's 6. So we're going to stretch out our shoulders. Stick your arms out like that. We're going to go from left to right, from right to left. We'll do 2 sets of 6. So, that's 1. 1. I'm sorry. That's a left. That's 2. Oh, that's 3. Good stretch. That's 4. Good stretch. That's 5. And the last one, give it a good stretch. That's it. Good job. Good job. I will see you guys soon. Bye-bye. Bye-bye. See you soon.
Thank you, Maxine. See you soon.
You're welcome.
Next, we're going to introduce Patricia Lansley. She's going to start with our next session.
Morning, everyone. So for the speaker sessions, note there will be 5 minutes following each talk for questions. And if you can remember to type your questions into the Q&A box, we can get them answered. So our first speaker is Dr. Santosh Sarif. He's a associate professor of medicine in hematology and oncology at UI Health, and he's going to speak on kidney and renal health.
Hi, good morning. I'm going to share my screen here. Okay. Thank you for the opportunity to speak today. And it's great to be able to speak after Dr. Cantor because she kind of highlighted a lot of the important things about sickle cell disease, including the fact that we've improved mortality and survival in children, but we still have a lot of problems and things that we need to work on in adulthood. And kidney disease is one of those important topics that affects sickle cell disease and its health in our patients. It's currently estimated that heart, lung, and kidney complications account for about half of identifiable causes of death in our patients. Kidney failure is believed to account for up to 20% of deaths in our patients, and chronic kidney disease is one of the most consistent predictors for early mortality. A major problem was also those that advance to end-stage renal disease or require hemodialysis have a lot of problems, and about a quarter will pass away within 1 year of starting dialysis. Many different longitudinal cohorts have used different definitions for kidney damage. All of these have consistently shown that people that get damage to the kidneys are at higher risk of having more complications. So what is it about the kidneys that are so important? What are the functions that are particularly relevant in sickle cell disease? Well, one of the major roles is that the kidneys are important to prevent dehydration. They help our body reabsorb water and help concentrate the urine. But the part of the kidney that does this function actually gets damaged at a very early age in sickle cell disease. So it's really important that we maintain fluid balance to prevent this dehydration. Kidneys are also very important in telling our body to make red blood cells. So erythropoietin, or EPO, is a hormone that the kidney makes when it senses that the oxygen levels are lower. And this tells our body to make more red blood cells. And in people that have kidney damage, EPO goes down. And in people with sickle cell disease, if you have a low hemoglobin and your body's not keeping up with the anemia, this has been shown to be associated with low levels of EPO and leads to more complications. Kidneys are also the major site for forming the active form of vitamin D. Vitamin D is very important in maintaining bone health. And we know that vitamin D deficiency can affect the health of bones. And in a cohort from Emory, it was shown that people that are with sickle cell disease that have low vitamin D levels have more vaso-occlusive crises. And if you're put on replacement for vitamin D, you can actually get less bony pain. Kidneys are also really important in maintaining the acid-base balance. So they try to maintain the pH, or the acid and the base level in our blood at a neutral level. And this is really important for a lot of different protein function, but it also seems to affect how well the hemoglobin stays bound with oxygen. And if you have more of an acid level, the oxygen is given off, and this can cause more sickling in the red blood cells. And when you look at metabolic acidosis, which means that you have more acid than base, 21% of people with sickle cell anemia will have this versus the background population. And the kidneys are really important for maintaining our blood pressure. The kidneys regulate salt or sodium balance. They regulate this important set of hormones that we'll come back to later, renin, angiotensin, aldosterone system, which is really important for controlling blood pressure and probably heart health as well. And if you have problems with blood pressure control, this can subsequently lead to increased risk of other problems like stroke, signs of pulmonary hypertension or heart problems, and in kidney disease. So it's kind of a bidirectional relationship. Kidneys regulate blood pressure, and then blood pressure elevations can accelerate kidney damage. So how do we monitor for kidney function? And I want to break down the kidney into kind of the basic unit here, and that's called the glomerulus. And so what happens is blood flows in this filter. The kidney, the single unit, filters out the toxins, and this goes into the urine, and then all of the filtered blood returns back to the body. So this is the unfiltered blood flowing into the nephron. This is in the glomerulus, and the filtered blood, the cleaned blood flows out. And what passes through these filters becomes the urine. So we can monitor filtration of byproducts to estimate how well this filtering is happening, called the estimated glomerular filtration rate. And we can use two different proteins, creatinine or cystatin C, to do that. The other thing we could measure is damage to this filter. Normally, we want to keep our protein or albumin in the blood, but if this is damaged, protein, primarily albumin, will leak into the urine, and this is one of our earliest clues of kidney damage. So these are some of the things that we'll monitor when our patients come to clinic visits, as well as in the hospital. So just to kind of break down some of the pros and cons of these. The creatinine is readily available. It's what's most commonly used in the clinic and in the hospitals. The problem is that in people with sickle cell disease, this can often overestimate how well the kidney is functioning. We check this every 3 months. We follow it daily if somebody is hospitalized. And we use more stringent cutoffs than what the reference lab tells us. So if somebody has a creatinine over 1, try to be really cautious and try to be sparing with certain medications like ibuprofen or other antibiotics. Cystatin C is probably a better marker of something that's filtered through the blood. It's not as affected by sickle cell disease, so it's a little bit more accurate. It's a better measure of the eGFR. And what we try to do in clinic is we try to monitor this at least annually just to make sure that this creatinine is fitting what the cystatin C is showing. The problem is that it's not readily available and it may not be covered by all insurances. So this is something that needs to be checked before it's ordered. It also takes about 5 to 7 days to get the result back. So if you want to be monitoring this on a day-to-day basis in the hospital, then the creatinine is better. And then the other thing that we check is in the urine for albuminuria. This detects that early damage to the filter and predicts people that are going to have more advanced kidney damage. The levels can vary depending on what time of day it's drawn, so you want to get it consistently at the same time of day. And what we do is we check this in the clinic annually. If we start to see that this is going up, we follow it more frequently every 3 months. So when we look at chronic kidney disease, and this is defined by how much of that albuminuria is there and how much your filtration rate is, we look at it in our patients with sickle cell disease at UIC, and we reanalyzed this in a large multi-center study called the Walk Fast cohort. We saw that over half of our patients have some form of kidney disease. About a third of it is people that have that early damage where the albumin is being leaked into the urine. About 20% also have reduced filtration rates. When you look at this globally, our rates are pretty consistent with what's seen in many different countries where sickle cell disease is found, highlighting that this is an important problem that we need to monitor for and address. So what can help prevent kidney disease? So here are some lifestyle modifications that we'll go through one by one on the subsequent slides. But these include staying well hydrated, making sure your blood pressure is controlled, a low salt diet, high fruit and vegetable diet, and avoid smoking and being cautious with NSAIDs, medicines like ibuprofen or Aleve or naproxen. So staying well hydrated is important because the body has trouble handling dehydration in sickle cell disease. And this graph here shows that this is kind of the deeper part of the kidney where our body reabsorbs water. And this gets affected at a very young age. And so in people with sickle cell disease, it's really important to try to stay hydrated because this kind of inner layer here where the water is being reabsorbed is lost. So I'm very an avid fan of this 8x8 rule. Drink 8 glasses of 8 ounces of water per day. So things that count are water, juices, milk. Things that do not count are soft beverages or sodas, coffee, and iced tea. These will actually make you more dehydrated. I want to stick more to the left-hand side here, things that are going to hydrate you and prevent this dehydration problem. Another thing that's really important is blood pressure control. And the American Heart Association came up with these stricter guidelines in 2017, where an elevated blood pressure is the top number, the systolic blood pressure over 120, your diastolic pressure over 80. Sickle cell disease, we've actually known this for a long time. Dr. Gorduke was actually one of the first people to describe that even moderate elevations in blood pressure increases your risk for problems, including kidney disease and pulmonary hypertension. So it is really important to follow these AHA guidelines or American Heart Association guidelines, and these are relevant to people with sickle cell disease. One way to control blood pressure is a low salt diet. So on average, we eat about 3,400 milligrams of salt per day. Things that are really high in salt that we don't think about include bread and rolls, cold cuts, pizza, certain chicken, especially depending on how it's processed, soups, including all canned vegetables and sandwiches. The snacks also have added salt, as well as soft beverages. So the goal should be to try to limit your salt intake or sodium intake to less than 2,300 milligrams per day. And one place you can look is in the nutritional facts here. See the sodium, and you'll add this up. So you want to get less than 2,300 milligrams in a day. When you're looking at food items, look for these kind of key terms: low sodium, sodium free, no salt added, sodium reduced, or unsalted. And then just kind of track this and look at how much of your percentage that you're getting. You want to try to keep this under 2,300, both in sickle cell disease as well as in non-sickle cell disease. Another part that might be important for maintaining kidney health is the balance between your fruit and vegetable intake and your animal protein intake. So things like fruit and vegetables promote a more basic, less acidic blood level. Less acid leads to more oxygen being bound to your hemoglobin, which is very important in sickle cell disease because that inhibits the polymerization or sickling. In the general population, diets that have been supplemented with fruits and vegetables improves albuminuria, one of the early markers of kidney damage. In contrast, processed foods or foods rich in proteins have more acid levels. Acid leads to less oxygen bound to hemoglobin, which can promote red cell sickling. And in the non-sickle cell disease literature, increased acid type diets increases inflammation and promotes scarring in the kidney or fibrosis. And in people with sickle cell disease, when we looked at it in our group of patients at UIC, those that have higher acid levels in the blood have a threefold higher risk of kidney disease progression on follow-up. So it seems to be particularly relevant in our patients for their kidney protection. So the low salt and the high fruit and vegetable diet are great and they sound ideal. However, there's not only just educational barriers, but also real life barriers to low salt, high fruit and vegetable diets. And one of the biggest things that we need to work on as policymakers and providers is making sure that this type of food is accessible and affordable. And when we looked here, this is just some kind of preliminary data that we looked at. We looked at the Chicago area map, and the brighter green you are, the farther away you are from access to a grocery store. When you look at these bright green areas, these are people that have these red dots, meaning their filtration rate is declining over time. And the larger the red dots, the more faster the decline. And what we observed was that people with sickle cell disease that live in regions with less grocery store access have a more rapid decline in kidney function, really highlighting the importance of make sure our patients have access to low salt, high fruit and vegetable diet, and probably highlighting how important these are for kidney health. Another modification is avoiding tobacco smoking. This increases blood pressure, narrows blood vessels, and reduces blood flow to the kidney, and decreases the oxygen bound to hemoglobin. Most of the data is in the general population, where smoking increases the risk of kidney disease 1.6-fold. It's much higher in those that smoke heavier, and it's compounded on top of underlying risks like hypertension or diabetes. And this is probably relevant to people with sickle cell disease as well. Another thing is caution with NSAIDs. And NSAIDs include things like ibuprofen, Advil, Motrin, naproxen or Aleve, Torlac or Toradol, indomethacin or Indocin or Sulindac. Just some examples of them that you might see. NSAIDs do is they reduce the blood flowing into the nephron. So it kind of prevents this blood from going in here and leading to the function of the kidney, but it also reduces the healthy blood to keep the kidneys healthy. In children, Toradol increases the risk of acute kidney damage by about 1.6-fold during a crisis. And if we look at the filtration rate or blood flow to the kidney, people with sickle cell disease are particularly sensitive to these NSAIDs. Here, indomethacin led to a greater decline in glomerular filtration rate and blood flow to the kidney. And so it's really important to be cautious with this class of NSAIDs. They're useful for pain relief, but if you're going to take it, make sure you stay very well hydrated and make sure that your kidney function is being monitored very closely so that there aren't any earlier signs of kidney damage. What can we do to treat the kidney damage? Hydroxyurea has been our mainstay of treatment for over 2 decades. And there is data both in the pediatric group as well as in the adult group that this might help preserve kidney function. So hydroxyurea improves the fetal hemoglobin. It can improve the hemoglobin and lower hemolysis. And this leads to less hyperfiltration, one of the earlier stages that can damage kidney. And in this combined analysis, those people that were on hydroxyurea had more of a delay in when the albuminuria happened and the magnitude of the albuminuria. In adults, those that are started on hydroxyurea can help lower the amount of albumin or albuminuria in the urine. This is particularly true for the earlier stages for the microalbuminuria, but there is some benefit even in those that have more albuminuria. So it's important to monitor this. And if you see this in the kind of early phases, initiate hydroxyurea therapy because this is where you're going to get the most benefit. Other kidney-specific therapy that we've adopted from the diabetes literature includes ACE inhibitors or ARBs. And so what happens in diabetes, which is what we think also happens in sickle cell disease, is that the blood that's flowing in, blood that flows out is constricted. This leads to an increased backup in pressure within the nephron. And this increased pressure causes the proteins to get leaked. This can lead to damage. Well, if you give ACE inhibitors, this is what blocks the angiotensin production. Or if you give angiotensin receptor blockers, block the effects of angiotensin, this will help relax this part of the outflowing blood, lowering the pressure and help preserve some of this kidney function. So these have been studied in sickle cell disease. Two examples of ACE inhibitors were captopril and enalapril. And so these medications help lower albuminuria and seem to have an additive effect in this small subgroup of people given enalapril plus hydroxyurea. Then ARBs, the one medicine that we often use is losartan. This was shown to improve the amount of albuminuria both at Emory as well as a multi-center study that we were a part of, where people that were treated with losartan had a decline in their albuminuria, both with early stage as well as more advanced stages of albuminuria. So in summary, the kidneys are an important part of health in sickle cell disease. They help prevent dehydration, they help maintain red blood cell production and bone health, and they regulate acid levels and blood pressure. Ways to monitor kidney function: in the blood, we can do a test called the creatinine or the cystatin C. Creatinine is readily available, but has its limits because it's not as good of a measure of kidney function, while cystatin C is a better measure, but not often available. And then in the urine, we screen for albuminuria or protein being leaked out as an early marker of kidney damage. In terms of prevention and treatment of kidney disease, things to remember for healthy lifestyle is stay well hydrated. Remember water, some juices and milk count. Iced tea, coffee, sodas do not count. Careful with your blood pressure. You want to monitor this, and you want to try to keep this top number less than 120 and try to keep this number in the 70s or lower. Probably less than 70 would be better. In terms of diet, try to enrich your diet with fruits and vegetables, lower the processed or animal protein in that, and also try to be cautious with the salt and measure the sodium so that you're trying to get less than 2,300 milligrams per day. Avoid tobacco and limit NSAIDs, that class of the anti-inflammatory pain meds. And if you're going to take it, drink it with a lot of water and make sure that your primary care provider is monitoring your kidney function really closely. Other things that can help specific to sickle cell disease is hydroxyurea. Things that have been adopted from other kidney disease type states are ACE inhibitors and ARBs. And then something that I didn't mention, but early referral to a nephrologist. So if we're starting to see signs of this kidney damage, you want to have a nephrologist on board or a specialist in kidneys because they can help make sure that things like the acid levels are okay, your vitamin D levels are okay, and they're really great at helping regulate the blood pressure. That I'd like to acknowledge all the patients that have been involved in our studies. They really are the heart and soul of our program, and they help us understand how to help people in the future. The UIC group of people that have helped with a lot of the kidney disease work, like Dr. Victor Gorduk, people from County, Hectoin Institute, Dr. Singh and Dr. Gudahitlu, collaborators at the University of Pittsburgh, University of Ibadan, and Loyola University, and the funding support that we've obtained throughout the years through different institutions. Thank you.
Thank you, Dr. Saraf. There is a question in the chat.
Yes.
Is there evidence that drinking alkaline water is beneficial in sickle cell disease?
That's a good question. I've heard that before, but there's no evidence at this time that it is beneficial. It makes
And I
sense,
have,
logically, but
I,
no
I have a
evidence.
question. I have a question, Dr. Saraf, as well. You mentioned the Toradol, and I wanted to kind of know just a little bit about the Toradol, taking Toradol, because I do know just experience when you're in the hospital, or they always ask you how your kidneys doing before they give you Toradol. Can you kind of expound on that just a little bit? And then also aspirin.
Yeah. So good question. So Toradol is really helpful in helping to break the crisis. And my rule of thumb is that if your kidney function measures look okay, like if your eGFR is over 120, and you don't have any other signs of kidney damage, we usually give 4 doses for 24 hours and then try to limit it thereafter. We also make sure patients are always very well hydrated. If somebody has a lower filtration rate, that GFR, then I'm very cautious and hesitant to use it for a vaso-occlusive crises. In terms of aspirin, a low dose of aspirin should be generally safe to take, like the 81 milligrams. 325 milligrams can also be safe. There's not a lot of data on that that I'm aware of, but if you're going to take it, again, stay well hydrated, drink lots of water.
So so over a period of time, if you take the Toradol, does it cause problems in the kidney, or is it just associated with trying to make sure that you monitor the kidneys before giving it? Is that how
Yeah,
that
so
goes?
yeah, the rule, I think our hospital our team has kind of a rule that you're not supposed to get more than 3 days within a month because it is kidney toxic,
Okay.
and try to limit that even further to 24 hours. So you can use it. It's great at helping with the crisis with the other pain medicines, but you just have to make sure you're on IV fluids, monitor the kidney function really closely, and use it very sparingly.
Thank you so much for that. Get back to Patricia. Thank you.
Oh, you're welcome.
Thank you, Dr. Saraf. Are there any additional questions? If not, thank you, and we'll move on to our next speaker. So our next speaker is Dr. William Ennis. He's chief in the section of wound healing and tissue repair at UI Health, and he is going to speak on wound care and leg ulcers and sickle cell disease.
Thank you. I want to thank the organizers for being able to present today. I'm going to share my screen. So hopefully you can see that slide then. So just get confirmation. Okay, great. So again, thanks everybody to be able to speak on what I feel is a very important topic in sickle cell and a very misunderstood topic in sickle cell. So let me go through a series of slides. We're going to go through what is healing, what is abnormal healing, really briefly, but so that people can kind of understand. Then focus on sickle cell, leg ulcers in particular, the workup, the treatment. We've done some publications on some very large databases looking at sickle cell ulcers, and I'll talk about why that's important, and then some future directions for it. So in general, regardless of your wound etiology, if it's a venous ulcer, a sickle cell ulcer, an arterial ulcer, diabetic ulcer, these 4 phases have to occur. So initially there's some bleeding into the wound, platelets come in, try to help stop that bleeding. This is called the hemostatic phase of healing. This moves on to an inflammatory phase, which is mission critical. Every wound has to have an inflammation phase. The problem is monitoring that. Just like you heard the prior speaker talk about anti-inflammatories, you can do this and you can reduce the inflammation, but there has to be a low level of inflammation to even start the process. The problem is the majority of chronic wounds get stuck in that phase. They never progress to a proliferative phase, which is where other cells come in and the biochemistry is such that you start building the building blocks of scaffolding and granulation tissue, ultimately allowing your skin, your epithelium, to then migrate over that and close the wound. And even when we do close the wound in the adult for 6 to 12 months, there's something known as the remodeling phase. And this is where we kind of break down the wound, scar tissue, and rebuild it. And this is why in adults, we only heal at around 70% of the tensile strength of the original skin area. So if you re-injure the same area over and over again, you're basically looking at 70% of 70% of 70%. And this is why recidivism or wound recurrence is documented at the level of about 75% for patients with wounds in general, for all etiologies. Specifically in sickle cell, it can be 75 to 80%. So what is a chronic wound? A chronic wound is stuck in that phase where there's repeated trauma, there's decreased blood supply, and in an ischemic wound over time, the bacteria that are normally present on the skin start to play a more important role and start to impart negative impacts. And so biochemistry-wise, this is what happens. There's an increase in white cells that come into the wound, and then they degrade some of the normal tissues. Growth factors and the cellular matrix that we try to build, your body's kind of fighting itself at that point. So the wound is trying to heal and the inflammation is breaking it down. So if you were to take the chronic wound fluid and you were to bring it to the lab and you were to show, put that fluid into cells in culture, you would stop their growth, you would stop their ability to make growth factors. And we've proven this a couple of times. This was first published about 20-something years ago by one physician, plastic surgeon Bruce Mast and Greg Schultz in his lab at University of Florida. And they found that if you took chronic wound fluid, it could really shut down the wound healing process. And if you took acute wound fluid, you could actually accelerate it. And this is why products for wounds have been designed to wick away or absorb the chronic wound fluid and try to prevent it from being in touch or in contact with the wound bed. And this is not just sickle cell or diabetics. So we did a study out of Walter Reed Hospital on soldiers that had been unfortunately traumatized by IED devices, so lower extremity trauma to their soft tissue. And we collected the fluid that came out of the canisters that were protecting these wounds, and we were able to show very high levels of inflammation. So even in young, otherwise healthy soldiers who before that injury, there was nothing really wrong with them medically, the minute they have a wound, they have a high inflammation in the local level. So the chronic wound doesn't follow a normal sequence of healing cascades, and there are multiple complications. And because of that, patients often become frustrated and they start missing appointments and not following up because they too get frustrated by not seeing the forward progress of a wound. So that's what a non-healing chronic wound looks like. And so let's just transfer that knowledge into sickle cell. And first reported sickle cell ulcer in the literature, at least, was 1910. And what to me is very interesting is the prevalence distribution across the globe. So in the US, you can see a prevalence rate of 3 to 5%. That's at any point in time. In the lifetime of a sickle cell patient, it can be as high as 15%. But then you turn your attention to someplace like Jamaica, and in the sickle cell population, the prevalence rate can be as high as 75%. And the rest of the world, that is also true. Variable prevalence rates depending on, and this has a lot to do with genetics. It has a lot to do with the environment, heat, food, so access to healthcare. When you see this, why does this even happen? The pathophysiology of a sickle cell ulcer. And then you see a paragraph after that. Anytime you see that without a single sentence, it basically means we really don't know. And that all of these individual problems taken together impact somebody in their ability to heal a wound. So the microcirculation, the small blood vessels that feed our skin and soft tissue, that gets obstructed by the normal sickle cell process. But on top of that, a lot of patients have venous insufficiency that also makes that further negative on healing. The bacteria, as I stated, play a much more important role in the face of ischemic type wounds like a sickle cell wound is at the local level. Patients with sickle cell have a higher thrombosis or clotting, and they may not have deep vein thrombosis, but they do have at the microcirculatory level sludging. So you mix that with a low hemoglobin count, low oxygen carrying capacity. There's decreased nitric oxide, which helps with vasodilation. So when the hemoglobin is hemolyzed, it actually sequesters nitric oxide, which in the normal environment allows for the vasodilation. There's also some autonomic problems where there's vasoconstriction. So you put all this together, you have a tight, constricted microcirculation with a low hemoglobin, with venous backup, which causes further congestion in the microcirculation. You have an increase in thrombosis, and then you have these sickle cells that are occluding and mechanically obstructing the wound. So what we did initially in 2018 is took a look at a database from a large wound care company called Helogics, which I serve as a medical chief medical officer for, and we started to collect all of the patients across the country. But one of the problems is that no individual center sees enough patients with sickle cell, with a sickle cell ulcer, to actually gain expertise. And so not everybody has the benefit of being at UIC with a wonderful sickle cell department where there's collaboration, and we get to see a lot of patients with this situation. And over time, we start to develop better treatment techniques. So one way of doing that is taking all of these individual patients, 133 in this case, from 114 centers. So clearly each of those centers was only seeing 1 or 2 patients. We compared that to venous ulcers in 198 episodes on 427 wounds. What we found was that people with sickle cell ulcers are younger than those with venous ulcers. They have fewer underlying other complications. So most of the venous ulcer patients are older. They're also diabetic, hypertensive. They've got other problems. A larger size on presentation and the longer you have your wound with sickle cell is a predictor of poor healing, just like it is in any other type of wound. One of the differences, however, is in the wound care community, we talk about the improvement that we should see between the first time we see you and 4 weeks later as a predictor of whether you're going to heal. And we measure that as anything from 15 to 50% reduction. And then we start looking about how you're going to heal ultimately. The sickle cell patients actually have an increase in size in those first 4 weeks. And that was the first time that this was being published in the literature. And here's a graph that shows the age of the sickle cell patients, which are much younger, between the 20 and 45 age group, and the venous ulcer patients who are considerably older. And this also, on the lower graph in B, shows that sickle ulcers actually worsen in the first 4 weeks, and the majority of venous ulcers actually improve. And so this is a different way of looking at the Kaplan-Meier as a survival plot, looking at duration of the wound at the first time of assessment. So the older these wounds, greater than 90 days, the less they're going to heal. And then graph B shows the percentage reduction between 0 and 4 weeks. And again, the larger the wound, the older the wound, these graphs drop off dramatically and people just don't heal. So the mechanism of the ulcer actually forming becomes this occlusion that we talked about. And simple abrasions, you can simply bump your leg against the coffee table and get a small skin tear that should not really be a problem. But in this scenario, it becomes a problem. What's really intriguing to us is patients, just like we talk about sickle cell crises in other parts of the body. So the bone crisis, the chest wall crisis. A patient who's had an ulcer before will actually sense where the wound is going to be, and they feel pain in the skin before the ulcer presents. This becomes a problem in those that do not see this and treat this often, because the patient will go to, let's say, an urgent care center and say, hey, I'm going to have an ulcer right here, and I'm in pain. I'm going to have a crisis. And that person thinks the person's drug seeking, and they've never heard of such a scenario. So, but if you were to give pain medicines, hydrate that patient aggressively, and use oxygen, possibly transfuse that patient, you could mitigate against the formation of that. Hemolysis, as we said earlier, leads to hemoglobin sequestering the nitric oxide, so that's a problem. And what we're now seeing, as we routinely study all of our sickle cell ulcer patients for venous insufficiency, they seem to have a higher prevalence, clearly, than people at that young age would normally have. They're hypercoagulable, and so they have reduced levels of factor VIII, protein S, antithrombin 3. This further makes the problem great in the microcirculation. And again, I've talked about autonomic dysfunction. There's this vasoconstriction that occurs, and the bacteria play a bigger role. So where are these ulcers located? Well, they're almost always at the ankle level, over the ankle bones, both on the inside of the ankle and the outside. And that's because those regions actually have very little subcutaneous fat, and the microcirculation is actually poor there to begin with. So it's a high prevalent site. They're painful, and the pain is way out of proportion to the size of the wound. This is also problematic for the sickle cell patient trying to explain their symptoms to a provider that's not seen this before. And the other thing, it's more common in males, but what I want to point out is that patients with sickle cell ulcers are actually, these are a marker for higher risk advanced disease. In particular, pulmonary hypertension, priapism, and renal disease, as we just heard from on the prior speaker. So it is really important to have, again, we're fortunate in that the patients are coming from a sickle cell clinic in our situation, but in many centers where this is not commonly seen, a sickle cell ulcer should make a wound clinic ensure that the sickle cell patient is being cared for by a sickle cell provider, wherever that may be in whatever community you're in. And again, the recurrence rates are really high. So Katerina Meniti, a NIH sickle cell researcher over many years, published this paper back in 2010. And she showed that not only was there a decreased overall survival in patients that were sickle cell ulcer patients, but that there was a significant prevalence of tricuspid regurgitation, in particular measured by the velocity of that regurgitation. And this makes sense because the right ventricle is now squeezing up against a high resistance pulmonary bed in a patient that's going to have pulmonary hypertension. And this is also why there is an increase in venous insufficiency, because that backup through the regurgitation into the right atrium backs up into the cava, and the inferior vena cava then provides almost an outflow obstruction for veins. So these things are connected physiologically, and we should expect to see these things, and we should be aware of the fact that people that have these sickle cell ulcers need to be addressed and worked up for these other issues. So in 2015, Dr. Altman, who's one of our associate professors and was a previous fellow in wound care of mine at the University of Illinois, along with Katerina, Dr. Quigley from hematology, and others, put together a treatment algorithm where we looked at topical agents and dressings. We looked at the research on the use of platelet gel, low frequency ultrasound. And just like, again, the prior speaker, you borrow from diabetic renal disease, some of the treatments that make sense there also make sense for sickle cell. Well, the same can be said about venous ulcer and sickle cell. So systemic therapy, we always consider zinc supplementation. We use a drug called Trental, which helps deform their RBCs, and we have found very successful use in treating leg ulcers with Trental and sickle cell. Hydroxyurea is kind of an interesting double-edged sword. It is your go-to therapy in sickle cell treatments, but at the same time, there is a small percentage of individuals who actually develop a leg ulcer because of the hydroxyurea. So if somebody presents to us with a leg ulcer, they're on hydroxyurea, we try all of the other things first, especially if that drug is working really well for them. Until all of the other things are ruled out, do we speak to our sickle cell colleagues and say, is there any other drug we could use, even for a short 2 to 3 month term, to see if that changes the ulcer healing. Blood transfusion, the literature is sort of all over the map about whether it's 8, 9, or 10 grams of hemoglobin that is necessary, but clearly we want to maximize that to the best that we can. We also use an antibiotic known as doxycycline, not only for its improvement in bacterial counts, not infections, but dropping the actual count, but it's a very highly anti-inflammatory medication that doesn't carry with it the same problems on the renal side as was described again in the prior speaker. So these are some of the systemic therapies, and then we use a series of wound care dressings. And one thing I will point out that is we have been fairly aggressive in our use of something called Apligraf. which is a human skin cultured product. So it's neonatal foreskin tissue that is cultured out into Petri dishes, and it looks like human skin, and it is in fact living tissue. And we apply that in recalcitrant, hard to heal sickle cell ulcer patients. Not only do we see phenomenal results about healing, we also see a tremendous early, quick reduction in pain. And so patients who can't even allow that area to be touched within a couple of weeks of application of the first dose of Apligraf oftentimes have improvements. How can we prevent them? Bed rest and compression therapy, ACE wraps, venous stockings are tremendously useful. Pain management with all the caveats previously mentioned, scary stuff to use, but it's important. Hyperbaric oxygen has been shown in anecdotes and in case reports, but there's no randomized control trial and there's no insurance approval for HBO, but there's a bunch of reasons why we would think it would work. We do study all of our patients for venous insufficiency and treat accordingly. So for example, our young patients may have superficial reflux adding to their problem that would benefit from a vein ablation procedure. So we've incorporated our vascular team into this as well. Prevention includes skin moisturization, protecting yourself from having cracks and dry fissures, and then nutritional repletion. This is part of the paper that we published, sickle cell ulcer. We do blood work on everyone, some of these labs that you see. We do sometimes imaging. We're not usually suspecting osteomyelitis, but it is something that we may need to rule out. But venous insufficiency we do on all of our patients. If it is positive, we then combine sickle cell therapy with venous therapy, including Apligraf, the drug I talked about, Trental, and compression therapy. And we also have a low tolerance to treat the bacteria that are present in the wound bed with most often doxycycline. So let me go back to my regular screen. I'll stop sharing and see if there are questions.
Hi, Dr. Ennis. Thank you. There is a question.
Okay.
Has anyone else experienced a type of healing of an ulcer from a rough skin texture to a smoother skin texture after having COVID and receiving the treatment for COVID?
So I'm assuming this is with or without sickle cell. This is really more of a COVID wound healing question. There has been phenomenally interesting data on the impact of COVID at the microcirculatory level and wound healing. COVID in and of itself is a procoagulopathic condition. And we have seen in the past 18 months a significant increase in biopsy-proven ulcers that are showing intraluminal clots in patients that were previously COVID positive. And this is consistent across the country. It is one of the reasons why there has been such an improvement in survival on patients admitted to hospitals with COVID who are anticoagulated. If you remember, it really took us a few months before we started to see that full anticoagulation actually improved survivability for COVID. We're actually working on a study that should be starting soon with folks at Mass General on a device that actually measures the strength of the clot and trying to personalize the blood thinning regimen for those individuals. It has been shown that COVID patients have clot strength that is significantly different than non-COVID patients. So my fear in people that have sickle cell and other conditions like that, that COVID probably plays a little bit more of an important role in the microcirculation.
So that I have a question. This is Miranda. So outside of the COVID part, the same question applied with just like you said, just a sickle cell. Does it heal? You have patients who actually have healing where the skin actually kind of gets softened again for sickle cell patients.
Yeah, so no, I don't think that the skin quality is that different, frankly, from the venous ulcer patients. You see depigmented skin for the most part. Again, we do not heal as adults in regeneration. We heal with repair, which means we make scar, we don't make the resultant tissue. So you're not healing normal skin again. So there is some qualitative changes, but I don't see significant differences in sickle cell healing than in straight out venous healing. I do see a higher recurrence rate, without question. In fact, I have a patient right now that this is probably the fourth time she has had this wound. And with each time, I find it more and more difficult for us to achieve closure. So, the healing process, the 70% of 70% is real, but the quality of the skin seems to be adequate.
Is it in the same spot or is it different spots that it pops up in?
So,
Different spots.
good question, it's both. The
Both.
more common is the same spot, but certainly what we see is in and around that region, new wounds do crop up.
Okay. Thank you for that. Thank you.
Is there a Tariq that has a question? You can unmute yourself and ask. Are there any more questions for Dr. Ennis?
One more with the zinc. It says, explain how hemolysis leads within with the zinc. I think that's what it's saying, hemolysis.
Yeah.
It's key to zinc.
The data is mixed. It's not strong randomized controlled data, but so Dr. Altman in particular, when he wrote that paper, he does monitor zinc levels prior, and if there's a zinc deficiency, he will replete. He's not using it universally on each individual case. There are other papers that say you should supplement. So some people have some GI problems with doing that. Like I said, it's about 220 3 times a day. So, and the other medication is 3 times a day, and it also has GI side effects. So we try to have people eat food when they're using these medications, and we try not to use it on every single person so that we're not causing another problem for the individual.
There is another question in the chat. Is there evidence that leg ulcers will be helped by the newer medications for sickle cell, such as glutamine, boxylator, crizanlizumab, especially boxylator because it reduces hemolysis?
Yeah, there is not, again, I had to use a 1 million plus patient database in order to find the number of patients I found with sickle cell to publish that paper in 2018. So at this juncture, there's not, because there's just not enough patients added together. Again, it's a smaller percentage of the sickle population that get it. And so the next time we query that large database, we're hopeful that we'll be able to have enough patients with a subgroup analysis that are on these newer medications and then add them to those graphs that I previously published, but I don't have that data yet.
That was a very good question. Yeah, from the new medications, because I think Relexor is that's the Ospirita, I think that is. Then one is in the chat. Relexor, that's the Ospirita, I'm thinking, right?
It's a great question, because certainly those mechanisms directly add to the formation of the ulcer, right? Again, the problem is we need large numbers to see trends. And so we're very well aware of that question, and that database is still active and we are still collecting folks. So I'm hopeful that I'll be able to report on that. Maybe for your next year's conference, I'll know some more.
Yes, thank you.
We have one more question for Dr. Ennis. Are there different types of preventative exercises, such as walking, et cetera, that increase in circulation to the feet and legs that can lower the risk of ulcers?
A great question. The one thing that people in this country don't want to do, and always ask me for a pill for their venous disease, but in the UK, where a lot of these medications and therapies and grafts are not approved, there's really good evidence that even one of those ergonomic pedals, like small pedal, like mini bicycle pedals that you put under your desk, that you move your foot up and down, it's very well documented that if you increase the gastric pump, so that's your calf muscle pump, if you do that on a daily basis, you will increase the ejection of blood from your venous system out, and you will achieve equivalent outcomes to those people that are using compressive wraps. So, the best way to do that would be do both, keep those feet pumping, keep the calf muscles pumping, And that's at least one of those possible causes that I talked about, that there's a direct opportunity. You can't really fix your own thrombotic issues. You can't really fix some of these biochemical issues, but you can improve the function of your calf muscle pump. So great question. And at your next 15-minute stretch break, have everybody do some toe risers and get started.
Thank you.
Okay, Dr. Ennis, before you go, there's one more quick question. Is pig skin still being used to heal ankle ulcers?
That's
Yeah,
true.
so I wouldn't call it pig skin. There is a product that is part of the submucosal lining of the intestine of a pig. And that is probably the one product that we use. I would say that in the past 5 to 10 years, human-derived tissue, both cadaver-based skin products and human cultured skin products that I described, Apligraph, are being used and have better evidence. In particular, the benefit of pain reduction is so powerful that we've migrated almost 100% to using those.
Oh, yeah.
All right, Dr. Ennis, thank you so much,
Thank you.
especially for answering all those questions.
No problem, and enjoy the rest of your conference.
Okay. Our next speaker is Dr. Jerry Krishnan. He's the Associate Vice Chancellor for Population Health Sciences and a professor in medicine and public health. He will speak on pulmonary health and sickle cell disease.
Great. Good morning, everybody. I was trying to look at the clock if it's morning or afternoon already. I want to first congratulate all of you for putting on this really important summit. There's nothing that makes doctors and researchers more excited when patients take charge and help us understand what are the things we should be paying attention to. And so I hope all of you are enjoying it as well as all of us listening and participating. I'm going to talk a little bit about lung disease. I am a pulmonologist. So if it's okay, am I allowed to share my own screen? Is that allowed? Just want to make sure. Okay, very good. So let's see if I can make this work. All right, let me know if you all can see something on the screen that says it's got my name on it. Can you all see it?
Yes.
Great. Thank you very much again for the invitation. So the title of my talk is really asthma and pulmonary disease in people with sickle cell disease, and I'm going to tell you why I included asthma in just a few minutes here. Before I get started, just wanted to disclose that a lot of my time is spent conducting research. I want to thank the National Institutes of Health and other groups that have been helping us make some discoveries that are helping people with lung disease. I'm also an expert panel member for the recent NIH guidelines on asthma, as well as a member of the GINA group that conducts and reports on global reports on guidelines for asthma. Here are the 4 topics I'm going to try to cover today, and I'm going to leave plenty of time for conversation and discussion as well. If you were to ask me what are the different ways in which sickle cell disease can affect the lung, I'll say, well, there's probably 4 ways, and the 4th one is something we're still learning about. First, of course, is anemia, and we'll talk a little bit about that soon. Something called acute chest syndrome. Third is that people with sickle cell disease, of course, can have other health conditions, and the one that's studied the most is asthma, and we'll talk a little bit about how that can affect sickle cell disease and vice versa. And then lastly, there's a lot of discussion right now, of course, about COVID. It's a pandemic, and what do we understand about sickle cell disease and COVID-19? So why don't we get started? The first is that a complication of sickle cell disease is, of course, anemia. I think all of you know that. It's been discussed by various speakers. And it's important to understand that anemia essentially is a term that we use that's important, that basically says there are fewer red blood cells. So why is that important? Well, we know that red blood cells carry oxygen to the various parts of the body. And when you have what's called hemolytic anemia, essentially where the red blood cells are getting damaged and breaking apart from sickle cell disease, that there's fewer functioning red blood cells in the body. And because of that, there's less oxygen that gets carried to the various parts of the body, including the brain, the kidney, the heart, the legs, and other places as well. And that actually can lead to difficulty breathing, something we call dyspnea. And it's predominantly on exertion. So when people are walking around or taking a flight of stairs, but can occur if it's severe enough, if the anemia is severe enough, as well as when you're sitting reading a book or watching TV, or if you're looking outside your home. One of the more feared complications of hemolytic anemia and sickle cell disease is that it can lead to something called pulmonary hypertension, which is another word for saying high pressures in the blood vessels of the lung. And that can further lead to problems with heart function and more difficulty breathing. So as we think about how do we prevent anemia, I think, and since this whole conference is about prevention, I think the number one thing to do is to think real hard about what can I be doing in order to keep my sickle cell disease controlled. And of course, among the most important of the things we could be doing is, hydration and having a good night's sleep and so forth, but also to think a lot about hydroxyurea as a way to keep the amount of sickle cells in your blood as low as possible. Well, the second way in which sickle cell disease can affect the lungs is something called acute chest syndrome, or ACS. And the causes of acute chest syndrome are likely multiple, but the ones that we tend to think about the most, or the ones that have the most evidence to support, are essentially infection, such as if you get an influenza in your lung or any other pneumonia in the lung, that can trigger acute chest syndrome. Something called fat embolism, which is where you have damage to the bone marrow because of sickle cell disease. And as a result, fat droplets come out of the bone marrow, and can travel to different places and get trapped, such as the lung. And then finally, if you have enough sickling going on in the lung blood vessels itself, well, that can lead to different parts of the lung having infarction, or essentially getting damaged enough that that part of the tissue dies off, and that can lead to acute chest syndrome. This cartoon that's drawn here is by Dr. Mark Gladwin and others back from a number of years ago in one of the medical journals. And you can see here, if you start at the bottom, that you can have in many cases what's called shunt. So the blood flow in the lung is abnormal because of the sickle cell disease, and that can lead to lower levels of oxygen delivery. And because sickling doesn't allow oxygen to bind properly to hemoglobin, can distort the shape of the hemoglobin and the blood cell itself. That can lead to certain parts of the lung itself having hypoxia or lower levels of oxygen. And as all of you know, vaso-occlusive crisis, or sickle cell crisis as we call it, occurs because what's a normally shaped red blood cell, which is at the top of the screen, can turn into a sickle shape, if you will. And these can create clumps that essentially create clots in different parts of your body, including the bone marrow, where fat droplets can be released that then get into the lung. So if you will, acute chest syndrome can occur because of several reasons, but in some ways, all of these relate back to how sickling affects normal blood flow and healing from infections. So as you think about acute chest syndrome, what happens ultimately is that there is a problem with blood flow in different parts of your lung, and that can lead to damages in the lung, which we sometimes call lung injury. And most patients with acute chest syndrome then go on to have chest pain, fever, difficulty breathing. They can wheeze as well, cough, or have lower levels of oxygen in the blood. And while acute chest syndrome in most cases does get better with conservative management, often, but sometimes it can rapidly progress into someone being unable to breathe altogether and requiring support in an intensive care unit. Acute chest syndrome actually is a very common cause for hospitalization after sickle cell crisis affecting the long bones. acute chest syndrome is really number 2. So it's a common problem that we see in people who are in the hospital. So how do we do something about it? How do we prevent it or treat it? Well, in terms of prevention, I think one of the more common ways or important ways to prevent acute chest syndrome is to get a vaccination. So prevent infections from taking root to begin with, because infections both in the lung and outside the lung can trigger acute chest syndrome. So pneumonia vaccination, influenza vaccination, and now with COVID-19, a COVID-19 vaccination is going to be important. The second is to keep sickle cell disease well controlled, and hydration is important, but also hydroxyurea and other ways in which you can manage sickle cell disease. If you develop acute chest syndrome, then the treatments are relatively non-specific right now. We don't have medications specific to acute chest syndrome, but in general, the treatments that we use are more supportive, such as hydration, blood transfusions, antibiotics, and oxygen. Okay, so let's go on to the third topic, which is sickle cell disease and asthma. I'm sure many of you have heard that these go together. And in fact, we know that about 12% of all children in the United States have asthma. In the African American community, it's even higher, as much as twice as high, from 15 to 20% of African American children. And among adults, it's about 10% of African American adults. Although it's not 100% clear, the best knowledge that we have currently is that the prevalence of asthma or how often asthma occurs is not necessarily higher in people with sickle cell disease. Most of this data is in children, and it doesn't suggest that because you have sickle cell disease, you have a higher risk of asthma. Fundamentally, I think our current thinking is that sickle cell disease affects a similar population as have a risk of asthma, and so these two tend to go along together. So as far as we know at this point, sickle cell disease does not actually cause asthma. It's just that these two conditions are common in people who have both conditions. Well, how does coexisting asthma affect breathing in people with sickle cell disease? The first thing to know is that when you have asthma, which is a chronic disease, it reduces your lung function. The amount of air that goes in and out of your lung is affected, and the blood vessels as well are reacting to that reduced ventilation, as we call it. And there are regional areas of low oxygen tension because of asthma. And that can then trigger essentially sickling of the blood vessels that are circulating into your lung. So asthma can in fact trigger sickling in people with sickle cell disease because blood flow can be abnormal in people with asthma. We also know that asthma can increase the risk of poor health outcomes, and including mortality in people with sickle cell disease. So this is a situation where, although sickle cell disease does not cause asthma and asthma does not cause sickle cell disease, having both essentially increases the risk of complications from sickle cell disease. So the most important thing to do if you have coexisting asthma is to keep your asthma well controlled. Work with your doctor to avoid the asthma triggers and use the medications as prescribed. And so learn really about empowering yourself to figure out what can I do to keep my asthma controlled. Last, and then we'll have some time for question and answer, is what about COVID-19 and lung disease in people with sickle cell disease? Well, the first thing to know is that there are higher rates of more severe, looks like there's a typo on this slide, a higher rate of more severe COVID-19 in people with sickle cell disease. So the Centers for Disease Control has listed sickle cell disease as one of the conditions that increases your risk of complications from COVID-19. And there's a lot of work that needs to happen in this area. How does sickle cell disease increase the risk of more severe COVID-19? We don't know exactly how that occurs, and that's an area that hopefully we're able to understand and bring that back so we can avoid it. One of the areas in which UIC is making an effort is that we were recently awarded a NIH project called Recover. And some of you may have heard of this, but maybe as high as a third of people who develop COVID-19 don't recover as quickly from it, and for weeks or months or even longer, still having the after effects of COVID. UIC is leading an Illinois-wide center on long COVID, and the name of the study is called Recover. And although it's not specifically an objective right now of the Recover program, I think we should be thinking about how to leverage this particular new study to study how sickle cell disease affects recovery from COVID-19. This is a very large program that's a federally funded program with 14 centers across the country. And this is an opportunity for the UIC team here to work with our patients to better understand how sickle cell disease affects recovery from COVID-19. So I'm going to end by just summarizing fact that we've talked about 4 different ways in which sickle cell disease and lungs go together. We've talked about hemolytic anemia and how that can trigger pulmonary hypertension. It can trigger difficulty breathing, particularly on exertion, and the importance of keeping sickle cell disease controlled to reduce as much as possible these consequences. We've talked about how infection, fat emboli, and other problems, including pulmonary infarction, can create acute chest syndrome, and that acute chest syndrome is a common cause of hospitalization, and that we don't have specific treatments for acute chest syndrome. So really keeping sickle cell disease as well controlled is important. We've also spent some time talking about how sickle cell disease can coexist with asthma. So some people can have more than one health condition. And if so, keeping asthma well controlled now becomes also a priority. So taking care of your sickle cell disease and asthma as well. And then finally, we're in the middle. I don't know if we're in the middle or the near end of the pandemic. It certainly feels like we're still in the middle of it, but more work needs to be done to understand how COVID-19 and sickle cell disease affect each other and how it might affect recovery from COVID-19. So I'm going to stop there and turn it back over to the moderators, and happy to take any questions. Thank you.
Thank you. Are there any questions for Dr. Krishnan? You can unmute if you'd like and ask them directly, or type them into the question box. Let's see. Here's a question. What methods can be implemented to monitor hypertension for individuals living with sickle cell disease trait?
It's a great question. So for pulmonary hypertension, it's really it generally goes by pretty silently until it gets severe enough that you develop symptoms. So the first thing to do is to talk to your doctor about what do I have pulmonary hypertension? And the typical way in which we diagnose pulmonary hypertension is by doing an echocardiogram, which is an ultrasound of the heart. We don't know of any other way to non-invasively screen for pulmonary hypertension at this time. So in summary, first is to raise that question with your doctor. And second, the test that is typically used for pulmonary hypertension is an echocardiogram. There are some more specific tests that are more invasive, but I wouldn't recommend that as an initial step, really echocardiogram.
I have a question. This is Dorinda. We heard you say that asthma and sickle cell can coexist together. My question would be, can pulmonary hypertension and acute chest syndrome, because as a patient myself, sometimes they explain pulmonary hypertension different than acute chest syndrome. So can those two also coexist together, or is it something totally separate?
That's a good question. Am I pronouncing it right? Is it Datrina?
Katrina, this is Dorinda speaking. You say Katrina?
I'm here. Sorry, I'm here.
Katrina's there.
Okay, I'm sorry, I didn't know who was asking me that question. Could you say your name?
This was Dorinda asking the question.
Oh, okay, thank you. Thank you very much, Dorinda.
Okay.
I appreciate that.
Mhm.
Yeah, so I think that many of these things all can coexist together. So people can have hemolytic anemia and pulmonary hypertension. They can be coexisting. When you have acute chest crisis, you could have worsening pulmonary hypertension. Acute chest crisis, think of it as you know how people have a stroke, like a brain attack, or if you have trouble with if you have part of your heart that's damaged, you can have a heart attack. Well, think of acute chest syndrome as a lung attack in people with sickle cell disease. So you can have pulmonary hypertension. That's sort of an independent issue all by itself that predominantly occurs in people with hemolytic anemia. And then you have pulmonary hypertension that's just part of your sequelae or complication of sickle cell disease. And then some people can go on to have essentially a lung attack, which we call that acute chest crisis. So I would say these are different ways in which sickle cell crisis can affect your lungs. And in some cases, all of them happen together. In some cases, you don't have all of them together. They occur separately.
Thank you. Patricia, pray back to you.
Are there any more questions?
I think there's one from Terrence. I think Terrence posted something in the chat.
That's the question he just answered.
I had a question. Sure. I've heard conflicting reports about the SED community and how susceptible we may not be to it. And some people are saying that we have some protections against it. And maybe we're looking off of the old data because at the beginning of COVID, we're saying that we weren't faring worse than other people. But then you said that what you've seen is that we can affect us severely, or it can affect, we can be very affected with someone with sickle cell disease. But I've heard the doctors even recently saying that we haven't seen a lot of data suggested that we would do poorly if we did COVID. Can you explain?
Bridget, I was having some trouble hearing you. I don't know if it was just me, but I think you're talking about COVID-19 and sickle cell disease. Is that right? Okay. Could you, I apologize, but could you ask your question one more time? But I thought you were talking about can COVID-19 be made worse or have more severe COVID-19 if you have sickle cell disease? Was that your question?
Okay, I think. Hold on a minute. Let me mute myself on this. I'm connected twice. Okay. So what I've been hearing from some doctors is that they believe that people with sickle cell have a degree of protection against COVID. Are they going off of old data?
Great question. So, Bridget, that's a really good question. In fact, I was talking to Dr. Victor Gorduk earlier, about a week or two ago, and he was mentioning that they've not seen as much complications from COVID in people with sickle cell disease. And so I think this is an area that's still emerging, and there may be different sort of observations being made by different groups. What I was reporting on is what the Centers for Disease Control has up on their website, and they've also actually identified sickle cell disease as a condition of concern in terms of a risk of more severe COVID. So maybe the data will shake out a little bit more over time. You know, COVID-19 and every disease right now, it's in the frontier. So things are a little bit unstable. But I would say right now, based on what I know and what people are saying, that it looks like it could complicate, what happens to you if you were to get COVID-19. So I don't know if there are other physicians on the phone or other patients or clinicians that have a different point of view. I think this is a frontier. Everything about COVID-19 is sort of changing here, so we have to keep things in mind. But I was mostly reporting on what the Centers for Disease Control has concluded. Louis, I think you're on the conference. Do you want to say anything about this?
Yeah, just briefly, I put some stuff in the chat. So the risk does seem to be higher, but not sky high, which was what we had originally feared. so that as the COVID pandemic was evolving, the rates of deaths and complications from sickle cell did decrease compared to what there was at the very beginning. It is still higher, probably higher than the general population by like 1.5 to 4 times higher, but the statistics are pretty weak because the case finding people with sickle cell disease in those national statistics is hard to do.
Yeah. So I think, thank you, Dr. Su. And I think, right now, I mean, if something's 1.5 to 4 times as high, that's pretty high. But I think to your point, Dr. Su, maybe this is an area where people are still crunching the numbers and we don't have all the data in. My suggestion to everyone actually is do whatever you can to avoid getting COVID. It's just not worth messing with. And obviously that seems like a silly statement, but I think particularly to our youth, who sometimes, they're less worried about things. I think this is something really to reinforce, is that you don't want to get COVID-19. And not only could you get really sick from the infection itself, but there's also increasing concern about maybe long-term effects. Sometimes we call long COVID. They can create brain fog and headaches and fatigue and whatnot. So something to avoid. Even if all the data aren't in, I would try to avoid getting COVID-19 right now.
Yeah,
Get vaccinated.
This is Victor.
Thank you.
I'd like to agree with what you had to say. But I would say that here at UIC, we've been following the adult patients that we know of that have had COVID since the very beginning of the epidemic and tried to catch all of them. And in a way, an unbiased cohort. And to my knowledge, we have not seen a mortality with COVID-19 up to this point, for which we're really thankful for.
Well, that's a good testament maybe to both your patients, Dr. Gurdiuk, and the care that UIC is providing. And so I think let's keep that up. That's a good statistic to have. But I don't think we want to test it. And I think one other thing that Dr. Su put in there in the chat, just to highlight, is that it's not only about you, but we know that if you get COVID, you can spread it to people you love and care for. And so I think this is all about also from a public health standpoint, preventing an outbreak in your home.
Yes.
Thank you, Dr. Krishnan. Are there any other questions for Dr. Krishnan? All right, then we'll move on to the next speaker, who is Dr. David Topovic. He's a cardiologist and a cardiology fellow at UI Health, and he is going to speak on cardiovascular health.
Thank you so much for having me and for organizing everything and for the opportunity to talk today. I'm gonna try to share my screen here. Looks like everybody can see this, is that correct? Okay, so I'm just gonna get going because I think we're a little bit behind here on time. But as I mentioned, I'm Dr. Tofic. I'm one of the cardiovascular fellows here. When I was putting together this talk, I really wanted this talk to kind of share my thoughts as to how I approach care and heart care in those with sickle cell disease. And so I really targeted to those of you who are joining the call who have sickle cell disease and those of you who are providing primary care or who are first kind of line providers for those with sickle cell disease. Heart health and sickle cell disease has been discussed for about 2 decades now, but there's been kind of drastic changes in our views towards it. And to be frank, there's not a lot of adult heart doctors who specialize in it or who are really taking the time to get involved with it. And I think that's unfortunate and something that's going to need to change in the future. So we have our agenda here. I may skip a few things due to brevity's sake because we're a little bit behind, and I definitely want to leave some time for questions and discussion at the end. I have some support and funding. So I love this graph, and it kind of highlights why I think heart health and heart care and adult heart doctors getting involved in sickle cell disease is so important nowadays, right? And the reason for that, and one of the big reasons, is that when you look at life expectancy over the past 50 years in those who have sickle cell disease and the population with sickle cell disease on large, really life expectancy has increased, and it's increased at least in large part due to prophylactic and timely antibiotics and newer medications introduced in the 1990s, such as hydroxyurea. Okay, so patients nowadays with sickle cell disease live longer, and that's kind of causing us, especially as heart doctors, to rethink how we're approaching sickle cell disease. But as you can see, there's still a lot of work to be done, right? Whereas life expectancy in sickle cell disease has increased compared to the national average for all Americans, there's still this huge gap, right? And this gap is, this graph is only up until 2000, but if we stretch this gap, this 2-decade gap still exists. And we have to acknowledge it, and we have to focus on how to try to bridge that gap, okay? And when we study more recent kind of big data groups or larger populations with sickle cell disease, we see that both heart or cardiovascular and respiratory or lung issues make up a significant portion of complications that lead to harm and poor outcomes in sickle cell disease, right? Almost half. And this is big national scale data. But when we look at smaller scale studies, and this is a study that was done in Duke, it's kind of pretty well known, we see that multitudes and lots of lung and heart issues really make up what's driving death and harm in sickle cell disease, right? Things such as pulmonary hypertension, congestive heart failure, MI, and my research of focus is atrial fibrillation in these groups. Now, it's important to recognize, though, that compared to the general population without sickle cell disease, the reasons why some of these changes happen are different, okay? And I'll kind of get to that and allude to that in a second. So how do I approach care and cardiac care in sickle cell disease patients, okay? And as the population ages with sickle cell disease, right, I think that it's important to recognize that age and to recognize that there's kind of a new frontier in care for the sickle cell disease individual and the sickle cell disease patient. So the way that I approach it is I first recognize sickle cell disease specific risk factors. Okay, so we know that certain risk factors in sickle cell disease and certain findings are associated with harm and with poor outcomes. Okay, I then look at age and lifestyle specific risk factors, particularly in those patients that are more advanced in age. Okay. And so I get these two kind of risk factor sets, and then I think about what are the interactions? How is one influencing the other? Is one additive together? Do both of those combining produce harms? Is there something that I can do to prevent one? Is there something I can prevent to do others? And is there something that I can do to prevent harm from both of those at the same time? Okay. Now, before we dive into that and kind of talk further, I think it's good to just recognize and discuss a little bit about how sickle cell disease changes the heart and the blood vessels that come off of the heart, both their shape and their function, compared to the general population, okay? So let's just talk for a second. I'm gonna take a couple of minutes on this slide. Sickle cell disease individuals, even if they're pain-free, resting at home, watching a game or whatever show, tend to have larger heart size, okay? So the different chambers or rooms of their heart tends to be larger compared to someone without sickle cell disease. On top of that, they also tend to have increased thickness in their walls, okay? So larger hearts, more muscle, but that's not to say that those changes are necessarily good, right? Overall, individuals with sickle cell disease, and those who have it, your heart squeezes just fine, right? But there is very subtle changes, something that we call changes in strain or speckle tracking, that just on us, you don't feel it, but there's these very slight changes in how the heart squeezes. What we know that there's a even more increased risk of is that the way that the heart relaxes in sickle cell disease is different from the general population. Okay, a lot of these changes are due to the heart needing to pump more blood, and we do see that in individuals with sickle cell disease. On average, their parts, your hearts tend to pump more blood. All of these changes cause the heart to work more, okay? They just cause the heart to put in more effort. beyond these effects on the heart, we also see some other changes, right? We see, because of changes in hormones, kidney function, as well as heart function, we know that individuals with sickle cell disease tend to retain a little bit more fluid on board, intravascular volume, so they can be more prone to swelling. On average, individuals with sickle cell disease have slightly lower blood pressures. They tend to have slightly elevated lung pressure, so this usually is mild. And interestingly, there's differences in how the heart rhythm picks up or slows down, as well as changes in how heart rhythm goes from the top of the heart all the way down to the bottom of the heart, okay? Now, several of changes or worsening in those features of the heart in sickle cell disease are known to cause harm and death in sickle cell disease, okay? So we really need to try to understand these changes and try to target them. Now, what's necessarily normal or average in sickle cell disease is not average in the general and normal in the general population. And so for heart doctors and providers who don't have experience dealing with sickle cell disease, that can create a problem, and that can create difficulty in recognizing what's normal here, what's not normal here, when should I act, and how should I act appropriately, okay? On top of it all, when it comes to heart health, we have imaging tools, so how we take pictures of the heart, and we also have some diagnostic tools that can help us. But by and large, most of these have not been well studied within the sickle cell disease population, and some of them have been shown to have changes or abnormalities that are unique to sickle cell disease that may not require us to act. Furthermore, as a society, as a heart group in whole, we have guidelines and trials that have been done on large groups of people. But the problem is that a lot of these trials just didn't include patients with or individuals with sickle cell disease. And so we don't know if they're going to be helpful, right? We don't know if what we saw for one group is necessarily going to help us in the treatment of another group. And so this is why I think it's critical that every time we have a patient with sickle cell disease come in, or an individual with sickle cell disease, right? We say, okay, we have to focus on that patient alone. We have to have a multidisciplinary care team, right? And we have to practice what I call what's known as precision medicine, right? That we tailor our approach based on the best data that we have to provide optimal care for you. Now, I mentioned before that the population of the US with sickle cell disease is aging, okay? And before, just only, I think 15, 20 years ago, we thought that a lot of the heart risk factors in the general population are kind of less common in sickle cell disease. But a lot of the data that we have is focused on groups of individuals with sickle cell disease who are younger in age. And those groups are not necessarily representative of the sickle cell disease population in the United States today, okay? There's been some newer data that suggests that rates of classic heart risk factors, such as obesity, overweight, BMI, are increasing both in the pediatric sickle cell disease population and in the adult sickle cell disease population. On top of it all, we classically thought diabetes wasn't really common in sickle cell disease, but there's newer data that suggests, hey, maybe there is a group here that we should be targeting more aggressively. And we do know that patients, and Dr. Stroff, I think, pointed this out brilliantly, is that we do know that higher blood pressures in sickle cell disease increase risk for poor outcome. And so targeting high blood pressure in this group, and the criteria for high blood pressure has actually dropped significantly, right? So anything above 130/70 definitely warrants treatment. Kind of necessitates that we're more aggressive and that we screen more aggressively for this. So what are some of the issues that can arise in sickle cell disease? Well, there's quite a few, okay? Classically, we know that there can be something called heart failure or heart failure syndrome, where in sickle cell disease, it's common for the heart not to relax normally. And it was previously thought that the squeeze of the heart in most individuals is normal. But I'll tell you, as this population has aged, we most definitely have patients where not only is the relaxation of the heart not normal, but the squeeze is not normal as well. And so that needs to be recognized. Pulmonary hypertension, okay, like we've alluded to before today, the high pressures in the lungs. Those can be due to issues with the lungs themselves or the arteries that feed the lung, or they can be a result of abnormal relaxation from the heart. Atrial fibrillation, when my research is in, has been, classically understudied in sickle cell disease patients. And what atrial fibrillation is it's an abnormal heart rhythm that comes from the top of the heart or the upper half of the heart and increases the risk for a whole host of things in general populations, such as stroke, heart failure itself. And so we may need to treat this and screen for this more closely than we've been doing in the past. Okay. As I mentioned, conduction down the heart can be abnormal in sickle cell disease, and that can manifest or show itself as something called QT prolongation, which just means how the electrical current is it's different. It takes a little bit longer. What's worrisome about these is that these changes can lead to sudden death. And that's something that we've recognized as a big problem in our care towards sickle cell disease, and something that we need to really focus and try to reduce the risk or mitigate the risk as much as we possibly can. And I'm going to put two others on this list because, the classic heart conditions that affect the general population, we haven't really focused on them in sickle cell disease as much because prior data suggested that they weren't as common. But when you look at newer groups and older groups of sickle cell disease, we now know that valvular heart disease, which is the valves are the doors of the heart, they can have issues. They can either be too stiff or too leaky, as well as blockages in the arteries of the heart. Now, those can be the big arteries, which is more uncommon in sickle cell disease, or they can be the smaller arteries, which some data suggests is more common. So, the topic, I think, overall, and the theme for this conference today has been prevention. And when it comes to heart health and sickle cell disease, I can't, and in the general population, I can't say this enough. Prevention is the best treatment. And in order to prevent things, screening is key. So screening is key to prevention, and prevention is the best treatment. And in order to prevent things, and in order to pick them up, patients and individuals just have to get seen, right? So the office visit is that critical time. And this is kind of a little bit of a throughput algorithm that I use in my thinking, and kind of dictates how I would screen and how I recommend screening for heart health in patients with sickle cell disease. So, every single office visit, right? We do our standard routine stuff. We look for vitals. We'll do a symptom screen, right? Some sort of an exertional capacity assessment. Are you walking still 5 blocks? Can you go up a hill? Are you climbing 2-3 flights of stairs? Okay. And we also do a physical examination. And based on that, I think there's kind of two things that happen. One, everything looks normal or is stable from before, or there's abnormal findings. Okay. And so if everything is normal, what I encourage people to do is just what we call age-appropriate screening or situation-appropriate screening, right? So just because you're feeling fine and you're going to visits, right, doesn't mean that there's nothing that we're not doing at those visits, right? And that can include something that's checking the heart rhythm, checking the cholesterol, checking both the electrolytes and the kidney function, as well as checking for diabetes. Okay. Now, if there's abnormal findings, we do a further targeted assessment. And there's a whole host of things that we can do for them. I don't want to go too in depth, okay? But we can do things such as check blood levels for certain markers or proteins that are associated with changes in the heart. We can see changes in exertional capacity or how far people can walk. We can get pictures of the heart, and we can check the pressures in the heart and the lungs directly. The one thing I also want to mention is that we can also look and see how the heart rhythm is doing. And new data is suggesting that that's going to be of particular interest and critical in the care of those with sickle cell disease as they age. Now, typically, I see patients when they have abnormal findings or something doesn't make sense. And that's the usual referral to a cardiologist like myself, which I think is fine and completely appropriate. But I'm going to make the comment and suggestion that there's times when, even if everything's fine and the primary provider feels uncomfortable, okay, particularly in centers that don't have a robust multidisciplinary approach to sickle cell disease, as we do here at UIC, or we're very fortunate to have one, that you can consider referring to a cardiologist, particularly one that has a little bit more background in sickle cell disease, for us to do some age-appropriate screening or situation-appropriate screening. I'll get to what those two are in a second. So if you're an individual with sickle cell disease, okay, or you're a provider taking care of, what are symptoms cardiovascular that we need to keep out for? And I think most of us kind of know these, right? And kind of have a gist of this, but by and large, shortness of breath, okay? the inability to walk as far, by and large, right? That's telling me that, something is going on that you're not able to exert yourself more. And that can be a concerning finding, right? Lightheadedness or dizziness. So if you're feeling woozy, you're almost blacking out, or if you do black out, and I really want to emphasize this, if you do pass out, or if a patient of yours has syncope, that definitely requires more aggressive testing. Leg swelling, as well as nighttime coughing, can be signs and symptoms of issues. And then if you're feeling your heart racing, or what we call palpitations, you're getting extra heartbeats, things like that, that does warrant more workup, okay? As does new chest pain, new chest pressures, or things feeling different in the chest. And so to the providers out there, my kind of thinking is if there's any questions about anything heart related, especially in sickle cell disease, by all means refer. I mean, I'll tell you, I'm perfectly happy seeing patients, but for sure, if there's symptoms that you're worried about, please refer. Times when individuals may warrant some more testing is pre-sports or pre-exercise regimen evaluation, right? So mild to moderate activity, individuals want to start getting more active. We want to help risk stratify them a little better or see if there's changes, particularly because of QT prolongation and potential pulmonary hypertension. This may be the time that we want to do some extra screening. Preoperative evaluations, okay? And I'll point out that we have had individuals with sickle cell disease undergo open heart surgery in our institution and do just fine, okay, with appropriate preoperative management, care, adjustment. Poorly controlled hypertension. So if individuals are requiring, 2, 3 medications for blood pressure and we're not getting to target, and again, target is 130/70 in my mind, then that's a great time to refer as well. And I would argue that most patients, as they're getting to a more advanced age, which I would occur 40 years of age or above, this may be the time to think, hey, should we send them if, and I say this, if you're uncomfortable, right? So these are the patients who I do tend to do a little bit more workup to help stratify them further and see if there's things that I can target. We should note that if there's something abnormal, right? This is not a one-way door. There are therapeutic options and there's changes that we can make to your care that can be of benefit, right? That starts with to say and to have a multidisciplinary discussion between the heart doctor, the lung doctor, the hematologist, oncologist to say, hey, do we need to change sickle cell disease specific therapies? Okay. Beyond that, though, I think, two of the big targets for us, and Dr. Sroff mentioned this before, and I'm sorry if we're starting to sound a little bit like a broken record, but, lifestyle modifications, right? To decrease risk, right? Whether that's mild to moderate activity, weight loss, for sure, smoking cessation, as well as dietary adjustments, okay? Including low salt, increased fruit and vegetable intake. But it doesn't just have to stop there. If we identify other issues, there is medications that can help, right? And ACE inhibitors are now still recommended by ASH, I should say, American Society of Hematology, as the first therapy for treatment of blood pressure and sickle cell disease. But depending on what we find on the further testing, we can recommend things such as beta blockers, which slow the heart, diuretics, which help get fluid off. If we need blood thinners, we have different medications. And I hesitate to put statin therapy because there's not too many patients who are put on cholesterol medications for sickle cell disease, but there's probably a handful that I can think of. So in summary, right, heart and vascular issues are a common cause of harm in those with sickle cell disease. We know that sickle cell disease specific and age/lifestyle related care and screening is necessary both to prevent harm, because prevention is the best treatment, and to optimize health in those with sickle cell disease. Because there's differences in normal findings in those with sickle cell disease compared to the general population, and because our evidence and data hasn't really well been replicated in those with sickle cell disease, I think a patient-centered precision medicine approach with a multidisciplinary care team is ideal for providing optimal patient care. As I mentioned, prevention and early recognition is critical. Screening is the key to this. I'm a firm believer, particularly as this population age, that early referral to a cardiologist for cardiac specific care, including arrhythmias or changes in electrical conduction, is paramount. Symptoms do require earlier visit and more frequent visits. Therapeutic options are available to reduce harm. And with that, I want to thank all of you. I think I'm right on time. I want to thank all of the organizers for this and everybody who logged in. I'm happy to take any questions.
Thank you, Dr. Tukovic. Are there any questions? You can either unmute and ask or put them in the Q&A box or the chat. I'm not seeing any questions. All right, well, thank you again. We will move on to the next speaker to respect her time. We're a little bit behind. Thank you, Dr. Tukovic.
Thank you.
Our next speaker is Dr. Jennifer Lim. She is the Director of Retina Service at UI Health, and she is going to speak on ophthalmology and sickle cell disease.
Hi, everybody, and thank you for inviting me to participate in this very nice symposium. I'm going to go ahead and share my slides. So as you've heard, I will be speaking on retinopathy and the importance of seeking preventive care for individuals with sickle cell disease. These are my financial disclosures, none of which are relevant for this talk. So sickle cell disease affects the eye in a myriad number of ways, and I'm going to give you an overview first of the various ocular manifestations, and then focus on sickle cell retinopathy. And then specifically, we're going to talk about why preventive care and timely treatment are really important, in that we can identify the disease and stop progression, and hopefully identify patients at higher risk of progression and recommend potential preventive therapy. The ocular manifestations also include the outside of the eye, including the orbit. And here you see an image of a young man who has an orbital wall infarction, and another picture of a patient who has an infection. So with sickle cell disease, the pain can not only be from a crisis, but can also be from a resultant infection, which they're prone to because of the sickling. In addition, the front part of the eye is very sensitive to trauma, and patients can present, as shown on this picture, with a complete, what we call hyphema in the eye due to bleeding related to the trauma. And they can also have atrophy of the iris resulting from this. And it's really important that we see these patients early and promptly, because the blood in an eye in a patient with sickle cell disease can result in really high eye pressure and eventual blindness if not treated in a timely fashion. And we can actually give them IOP lowering agents, and if necessary, do surgery to evacuate the blood to prevent blindness. And a lot of this seminal work actually came out of the Eye and Ear Infirmary many years prior to my time by Dr. Goldberg, who worked intimately with the sickle cell folks at our university. Also, the conjunctiva can also show changes related to sickling. And frequently when we look at a patient, we'll see these segmentations of the blood vessels in the conjunctiva related to boxcar flowing, related to sickling of the retinal blood cells that we can actually directly see with our slit lamp biomicroscope. And this really has no consequences. It's just a curiosity that we see, and no treatment is necessary. What about the retinal complications? Well, the complications related to sickle cell can be very severe and include bleeding underneath the eye in the center, called the macular area, that can cause significant loss of vision if not promptly identified and treated. In addition, the retina itself, aside from the macular region, can also show changes related to sickle cell disease. And we tend to divide these into non-proliferative, meaning there are no new blood vessel formations related to the ischemia, or to non-proliferative disease, in which we see changes in the appearance of the blood vessels. So here's an image what you might see when you look in a patient's eye with sickle cell disease, and you'll see a lot of tortuosity of the veins as shown here. And in the macular region, you might see this dark disc-like area that looks gray, and that's called the foveal depression sign. And that's related to loss of retinal tissue due to multiple infarctions that were subclinical in the retinal region. The optic nerve can also show evidence of sickle cell crises going on, where you see little areas of dots where we have occlusion of the tiny vessels of the optic nerve head. And as I alluded to, the foveal depression sign is shown here. And this macular thinning may or may not be causing problems in the patient, but they really should be diagnosed so that we can warn the patients about impending visual loss. We can also see hemorrhages in the retina, such as shown here. And we call these salmon patch hemorrhages because they're a salmon colored area of blood. And these are important to find in a patient who may have no symptoms at all. And it's important because this means that that patient is possibly having new blood vessels form on the retina that can cause significant other problems aside from just bleeding. And treatment is sometimes necessary if that neovascularization is present. If it was just due to a blowout of the vessel because of occlusion from the sickle cell, we just observe those eyes. Another possibility is that the patient can have an occlusion of a major ophthalmic retinal artery, and that is an emergency. Patients will typically present with sudden visual acuity loss. And although intervention is rarely helpful, if we see them early enough, we can hopefully move that occlusion further down to a more peripheral part of the vasculature to try to help the patient regain some vision. What about this proliferative sickle retinopathy? Well, this is the most severe form of retinopathy that a sickle cell patient can get. And by this, we mean that they are developing new blood vessels akin to what diabetics develop on their retina. And these patients that are high risk of visual loss due to the neovascularization that's present. And the hemoglobin SC patients are the ones in whom this is most prevalent. And this does require treatment. Most often when you look in a patient's eye, you're going to see changes related to sickle cell, mostly in the peripheral quadrants of the eye, mostly temporally, as these are furthest from the source of the blood vessels entering the eye. And you can see here, I'll point out this, the picture on the right, this white color here to the retinal arteries. This is an occlusion related to infarction. And this patient may be completely asymptomatic. But if you look closely here, there's some other little blood vessels that are growing on the surface of the retina. And this is a patient we're going to want to follow closely and determine if that elevation of blood vessels is present. And if there is elevation, go ahead and treat the thigh with laser. We also see some changes in the periphery where the arteries connect to the veins. And these are called arterial venous anastomoses. And these occur because of the occlusion of the smaller vessels. And so we have to, if you will, create other ways for the blood to get from the arteries to the veins. And they're essentially shunt-like vessels that dilate. You might wonder, well, if a patient has these areas of AV anastomosis and has these areas of occlusion, is there any functional loss? And what our group at UIC has found that indeed there is functional loss. We can do tests called ocular coherence tomography, which show us the contour of the retina, as shown here. And you can see there's thinning here temporally. And this corresponds to what this attempts to show here on the left. And that is, we can project different size letters onto the retina or targets, and the patient can tell us whether or not they see that. And that's called microperimetry. And what our group has also found is that the function is decreased in these areas of thinning. So although their central visual acuity may still be good, they're actually losing functional vision. And this may explain why some patients come in and they say, well, you know, my vision's not quite right. It's a little bit fuzzy or cloudy, not right in the center, but kind of off to the side. And that is related to thinning. And we've actually studied this thinning. We have many, many patients, thanks to the Sickle Cell Center there for sending patients over to the retina clinic. And we followed literally hundreds of these patients. And we've published that over time, this retinal thinning does progress. And we've actually also found that hydroxyurea appears to be protective in such that the patients who are on hydroxyurea have slower rates of thinning than patients not on hydroxyurea, and also have less thin retina overall in a baseline cut compared to those not on hydroxy. And so we postulate that perhaps that's due to limitations of subclinical sickling in the eye and infarction, and therefore less loss of tissue because we're stopping that with perhaps the hydroxy or other interventions that you are treating your patients with. And again, similar to the other findings of sickle cell, most often these neovascular fronds called CFANs are most often found superior-temporally. And on the right, in case you're wondering what this is a fluorescein angiogram. We inject an arm peripherally with fluorescein dye, and we can take pictures of the retina, and we can show where the leakages are occurring due to these CFANs. So how effective is treatment when you have proliferative sickle retinopathy? Well, it's actually been shown, again, through a lot of work coming out of the Eye and Ear Infirmary back in the 70s and 80s, that the treatment is extremely effective. So you can take an eye that has neovascularization, as shown here. It's out in the periphery, so it's a little bit hard to see, and there's some bleeding. Here's a corresponding angiogram that shows the frond. And then after treatment, 6 years later, you can see evidence of laser, and you can see there is no frond and there is no more bleeding. And this patient has maintained excellent vision in that eye. Similarly, here's another eye that also had a little hemorrhage, and then post-treatment resolution of the hemorrhage and maintenance of vision. So these hemorrhages can be pretty severe. So here's a patient who presented complaining of decreased vision, and you can see that there's a large area of blood that is blocking the central macular region. So this is a symptomatic patient. The blood is still relatively contained in this eye, but this is an eye that laser alone in the clinic is not going to be enough. This is a patient who needs surgery to remove that blood and restore vision. Here are some other examples of how severe this proliferative retinopathy can be. Here's a patient with progression of the neovascular tissue into actual scar tissue, where it's elevating off the surface of the retina. And here's another example. One of my other patients has a lot of hemorrhage as well, pre-retinal and bursting into the vitreous, again, related to the proliferative sickle retinopathy. Now, this can progress on from just hemorrhage to actual retinal detachment. And so if you look closely here, you'll see that this area looks discolored, and you can see little white lines within the retina called hydration lines. And this retina is actually detached. So this sickle frond bled and then contracted. And as it contracted, it exerted traction on the retina and pulled off the retina. And this patient required surgery, and fortunately was able to be helped. So typically we stage the patients when you send them to us for screening, and we grade them using the quote Goldberg stages, which were developed by Dr. Goldberg, former chairman at the Eye and Ear Infirmary back in the 70s. So stage 1 is when we just see arterial occlusion. Stage 2 is when we see the arterial venous anastomoses. 3 is when they actually have the new blood vessel forming. Stage 4, vitreous hemorrhage, and stage 5, retinal detachment. Now, we can't prevent a patient, at least at this time, from getting stage 1 or stage 2, maybe stage 3 in the future, but not yet. However, we can prevent and slow down rates of progression. So we can hopefully prevent stage 3 from becoming stage 4 if we can diagnose and give timely treatment. And the diagnosis of that neovascularization is followed by timely treatment, typically with laser or perhaps with an intravitreal anti-VEGF injection. If it's not, however, caught, stage 4 can progress on to stage 5 of a retinal detachment, and then that patient, as I said earlier, will need surgery. So again, I think it's really important that we identify patients who are at risk for progression. The curve on the left shows what the prevalence of sickle cell retinopathy is according to age, and the prevalence of sickle retinopathy is highest in hemoglobin SC subtypes. And this chart is looking specifically at patients with hemoglobin SC subtypes. And you'll see that the prevalence of development of de novo sickle cell retinopathy with neovascularization here in this curve is typically highest between the ages of 10 and 30 and peaks in about 20 to 24 years of age. So these are young adults. So typically if your patient's already made it out here to 35 or higher, only about 10% of patients who develop new blood vessels are in that age group. So it's a little bit comforting if your patient's older. I usually tell my patient if they're in their, especially in their 40s or 50s, that it's highly likely that they're probably not going to progress on to the more severe forms if they have not already. Also, when we look at a patient, we look at the extent of the neovascularization, and depending upon the extent of the neovascularization that we see and other findings in the sickle cell, we can predict which ones are at higher risk for forming a retinal detachment, as shown here on the right, related to sickle cell retinopathy. This just shows how effective laser is when we treat these areas of new blood vessels to prevent vitreous hemorrhage and retinal detachment. The top line is represents the loss of visual acuity here. for the treated eyes compared to the untreated eyes over the follow-up, which is listed in months. And you can see that the laser is highly effective in preventing loss of vision. It's also effective in preventing development of vitreous hemorrhage loss of vision, which is a subgroup shown on the right. So what do we do? As I alluded to earlier, we can do surgery if laser is not going to be enough. And typically we'll do a vitrectomy, and this is done with the patient under local anesthesia. We don't require exchange transfusions. We do keep the patient very well hydrated during the surgery, and we do warm them up to try to prevent a sickle crisis from developing. Other things that we do is we keep the eye pressure at a relatively low, normal level to avoid sickling occurring in the eye and occlusions occurring in the eye as well. And we try to do expedited surgery to facilitate the patient not being under, not being under local anesthesia and lying on the table for some time. So typically we can remove the blood in under an hour. We can pair the retinal detachment usually in an hour at most to two hours. If it's very severe, it would take maybe up to 3 hours if there's a lot of scar tissue that we have to dissect off the retina. So here are some examples again, vitreous hemorrhage. We can help this patient, retinal detachment. This patient had 20/70 vision at the time of the retinal detachment, and then after surgery improved nicely to 20/25 vision. There have been research studies done looking at patients specifically with sickle cell disease and showing how nice an improvement in visual acuity we can get. So when the patient gets this, we counsel them, say, highly likely that you will have a significant improvement in vision. And you can see here on the left, the visions were ranging from hand motions, meaning literally they could only see somebody waving a hand. They can't read the eye chart. They can't see how many fingers are on the hand, to, some patients like my patient who was 20/70. Now, this chart on the right, you can see post-operatively how nicely the vision improves. There's a significant number of patients who are 20/20 to 20/40. So those are patients who are going to be able to legally drive a car without correction if they're 20/40 or better. So what happens if a patient, however, complains of sudden visual loss and they're not treated or they don't come in for some reason? Well, here's an example of a patient who had sudden visual loss in the right eye, fortunately was treated and got back some vision at 2200. But the left eye, which this patient had not had treatment in a timely fashion, this was many, many years prior to coming here, had lost vision, and this patient was essentially light perception only, meaning they could only see light and obviously legally blind and with a disfigured eye on top of it. Also, unfortunately for some of these patients, not only do they have a disfigured eye, but they also have a blind, painful eye, and the eye may also be shrunken. So we really want to try to prevent that for these patients. So why screen for sickle cell retinopathy? Again, bottom line is we want to identify the patients who are at high risk for progression and blindness. We want to identify those patients in whom we can intervene and deliver timely treatment. And then as a bonus too, when we examine these patients, we're also looking for other diseases, because just like other non-sickle cell patients, they may have untreated refractive errors. And so we can treat their myopia or hyperopia with prescription lenses. And then we can also identify other comorbidities in the eye, such as glaucoma and cataract, and treat or recommend surgery as needed. Thanks for your attention.
Thank you, Dr. Lim. That was excellent. Are there any questions for Dr. Lim? You can either unmute and ask them directly or put them in the chat, or put them in the Q&A box.
Hi, Dr. Lim. Miss Dorinda, how are you?
Good. How are you, Dorinda?
I'm good. Thank you. So you, as far as the preventive part of the, what we're trying to do, preventive, those who aren't really seeing an eye specialist for just, well, this actually kind of goes into seeing a specialist versus just a regular optometrist. So can you kind of expound on just between, I mean, I know you're probably both, but explain the difference between just like a regular checkup versus the specialist.
Yes, that's a great question. And, even people, physicians themselves always frequently get confused between optometry and ophthalmology. Mm-hmm. So optometry, I recommend for people who need glasses, you can't see far away, or you need reading glasses. The optometrist can do a good job of that. They can also screen to see if there's a cataract present. They can check your eye pressure. But if you have sickle cell disease, I would highly recommend that you see an ophthalmologist, because the ophthalmologist is trained in determining what stage of sickle cell disease you have, and then in making a timely referral to somebody, like me, a retina specialist, who actually has to put in laser or do surgery. And if they don't see that level, the ophthalmologist can very carefully follow for the determination of when that complication occurs. And if they're not comfortable, they refer pretty early on. So thank you for that question. I really think it's important for sickle cell patients to see an ophthalmologist.
Thank you.
You're welcome.
Are there any more questions? If not, we'll move on to our next speaker. Thank you, Dr. Lim.
Thank you so much for including me. Have a good day.
Our next speaker is Dr. Judy Fansu. She is a practitioner in Chicago who offers specialized dental treatments and preventative care, and she is going to speak on sickle cell disease and dental care. Thank you, Dr. Su.
Share, hit share.
Share, hi. Hello, everyone. Thank you so much. It's been an honor to be here. I'm so delighted to share with you on the preventive dental care of individuals with sickle cell. And I just wonder if you have wondered, how does having sickle cell disease affect oral health? And today we will explore these 4 areas. We will find out what it is: malocclusion, aseptic pulponecrosis, caries or cavities, and lastly, periodontal or gum disease. We will find out what it is, how to prevent it, and number 3, is there good evidence that this is associated with sickle cell disease? So are you ready? Here we go. First one, malocclusion. What is it? Malocclusion simply is when teeth are misaligned. On the left hand of the slide, we see the normal bite, how teeth come together in maximum function and aesthetic. However, on the right-hand side, we see an overbite, how the upper teeth is in front of the lower teeth. And can this happen in sickle cell? In this X-ray, we see bone marrow expansion in the maxilla that creating the upper teeth to be protruded out. So how to treat it? What is the treatment of choice? Is simply getting orthodontia or braces to correct the teeth position and the jaw relationship. And all those toothbrushes in the background is reminding us meticulous oral hygiene is the key to have successful orthodontia after the braces are removed. You don't want more problems. So next we ask, does having sickle cell disease predispose one to occlusion? And in order to find answers, my co-author and I searched globally. We found 13 sickle cell health guidelines, 13 global health guidelines with sickle cell, and 10 books. So these are the studies that we found that the level of evidence is moderate, it's pretty good, that sickle cell disease is associated with having higher incidence of malocclusion, but not every person has it, and genotype and disease modifying treatment could be cofactors. And this is published in last September, Journal of American Dental Association, September 2020. Okay, so this is on malocclusion, how teeth don't come together, maximum function and position. And now, next, we go to the next slide. Okay. So there is one study undergoing in Brazil for possible prevention for malocclusion. Is the study of the association between hydroxyurea. Okay. And next, we move to the second topic. It's called aseptic pulponecrosis. What is it? It's the pulp inside the tooth that dies without bacteria or other contaminants. How does this happen? Well, there are three major causes of why the pulp inside our tooth dies. In this slide, we see a cross-section of the tooth that has inside nerves and blood vessels. And the most common way for this nerve inside to die is cavities, as we see it in this second slide, how the cavities goes into the tooth from the top, from the side, from the root, and when it goes deep enough, affecting the nerve dies. And the second way is trauma, how we fell off the bike, how someone punched us, and the nerve reacts and it dies. And third cause, the least common cause, is aseptic pulponecrosis, is the death of the nerves and blood vessels inside the pulp without any infectious roots, such as in cavities and gum disease. So without signs of infection, the pulp suffers ischemia and tissue damage. And can this happen in sickle cell? We will find out. But the treatment of choice, whenever the tooth suffers necrosis, is root canal therapy. So under this first category of removal is root canal, which means the removal of infected and necrotic dental tissues, clean and debride the canals and fill and seal inside the canal. That's a root canal. After the root canal is done, the tooth needs to be protected to be restored, usually with a full crown, which is a dental crown to cover the whole tooth. And then the tooth, we get to keep it inside, I'm so sorry, to keep the tooth inside our own mouth, and any of our own tooth is better than any artificial tooth. So does having sickle cell disease predispose one to aseptic pulponecrosis? Again, looking at the studies from global guidelines, we found the evidence to be pretty good, moderate level of evidence. And sickle cell, under the summary here, can cause pulponecrosis with no infectious cause associated with low oxygen saturation on each one of the tooth. Pretty good study that used pulse oximeter and found the level of oxygen. Okay, so that is second topic. Now, third and fourth topic we're gonna go on is about cavities and gum disease and what causes it. And if you said plaque, you are absolutely right. As in this picture we see is a human plaque under the microscope, and plaque is that sticky white film on our teeth teeming with bacteria, live bacteria and dead bacteria. So if you go to this QR code, you will see the YouTube of this human plaque with the round cocci moving. I'm so sorry. The round are cocci and the long are rods. There are about 200 to 300 species of bacteria in everyone's mouth. And then this is a more powerful slide to see them with rods, spirochetes, cocci. So we know that if we remove plaque, then we can prevent cavities and gum disease, right? That's right. And what else can we do to prevent cavities? It has to do with this important concept of reducing the frequency of eating sugary snacks and sugary drinks, because more frequent sugary snack means more frequent acid attack and more cavities. What do I mean by that? In this picture on the top, we see 3 spikes of acid attack correlating to 3 meals a day. But if we have sugary snack in between the meals, we see a lot more frequent snacks because the bacteria in our mouth takes the sugar we eat makes acid, and the frequency of the acid will mean more likelihood of cavities. So what else can we do to prevent cavities? We learned two things already: removing the plaque. Second, reducing the frequency of sugary snacks and drinks. Third, we have a friend. We will find out what that friend does. It starts with an F. Here's a picture, molecular structure of our enamel, which is the strongest substance in our human body. And the enamel is a hydroxyapatite crystal made of calcium and phosphate molecule. And when it becomes weakened under the acid attack, if we have these Fs, their fluoride, which is also our friend, will help to remineralize those weakened tooth structure. So fluoride is our friend. That's the third thing we do to prevent cavities, and summarizing in this slide. First, removing the plaque. Second, decrease the frequency of sugary snacks and drinks. Third, remineralization with weakened enamel with fluoride. So does having sickle cell disease predispose one to cavities? And in the studies we found showed low level of evidence. There was mixed results whether sickle cell disease raises risk of caries. Penicillin, vaccination, salivary flow, and access to care are cofactors. So that moves us to the fourth category we're going to talk about, which is periodontal disease. And yes, it is infectious in nature. And in this slide, we see the four stages of gum disease. And remember, we talked about what caused gum disease. It starts with a P, plaque. Yes, if plaque is stayed on teeth more than 3 days, it becomes calcified, called calculus or tartar. And that irritates our gum, makes our gingiva, our gum, bleed and red. Is an inflammation process. And if that plaque and that calculus not removed, the tooth suffers some more, and osteoclastic activity, which means the bone will start to shrink. That strong bone hugging each one of our teeth will start to shrink and resorb. And if that continues, the plaque and the calculus not removed will move on to the advanced periodontitis. When so much bone has been lost, the tooth is so weakened and is so loose. And by this point, it's too late to save the tooth. But any point before the end stage, we're able to restore the tooth and maintain to healthy state. It's reversible from gingivitis back to healthy tooth, and it is able to maintain healthy tooth and gums, even at the periodontitis stage. So, because remember, plaque is so sticky, we cannot just rinse off with any mouth rinses. It's an adjunct to help prevent periodontal disease and cavities. So here we see different tools. We have electric toothbrushes, very useful. There are so many on the market. Make sure you pick a soft one. And there are also interproximal brushes. There are these little brushes that goes in between the teeth, as we see in this picture. And there are different sizes that goes into different space, the size of our spacing. And it does a wonderful job cleaning in between the teeth. And then there's also electric flossers, which now comes cordless, and you can put mouth rinse in it, and it goes through individual spaces in between the teeth. So these are adjunct to help us to maintain oral health, and prevention is one of the best medicines. And so we ask the same question again: does having sickle cell disease predispose one to periodontal or gum disease? And the evidence show that is low. under our studies, finding the different studies, it showed mixed results whether sickle cell disease is associated with greater periodontal disease. Again, if you're interested, it's published in the Journal of American Dental Association last September. So in summary, it's so important to have a dental home and to have good care coordination with our medical neighborhood. But I want to encourage each one of us that we're empowered to have beautiful smile that lasts all life long by removing, remember, the plaque, and brushing 2 times a day, 2 minutes each time. And I like this jingle that I teach to the kids. You don't have to brush your teeth, just the ones you want to keep. And remember, a clean tooth is a happy tooth. So that's the end of my presentation. If you have any questions, I am happy to answer. Thank you so much.
Thank you, Dr. Sue. Are there any questions for Dr. Sue regarding dental care? You can either unmute and ask the question or put it in the chat or the Q&A box. No questions? All right.
Thank you.
I'm sorry. I'm sorry.
Go
I
ahead.
have a question. I have a friend that regularly flosses with peroxide. Is that and her teeth are white as a result. She does it like twice a day after she flosses. Is that good or bad long term on her teeth?
That's a good question. Peroxide, has been found to reduce the bacterial count that causes periodontal disease. So the bleaching agent to make teeth whiter is peroxide. So if I think this is something she does need to be monitored, making sure it's not too much peroxide and it's not causing any other problems in the surrounding gum and other tissues. So if used appropriately, peroxide works very well.
Okay. I know she's been told to dilute it with water, so I believe she's doing that. And okay, thank you.
My pleasure.
Are there any more questions?
Yes. Can you hear me?
Yes.
How do you, this is kind of hard, which question like to answer in the interest of time. How do you protect enamel and how do you restore enamel of aging teeth?
That's a great question. How do you help to make your enamel stronger, right?
Yes.
Yes. By using fluoride. Remember the fluoride that comes into our mouth that will remineralize on our crystal, the enamel crystal, and combining with the calcium and the phosphate on our enamel, and the fluoride will make it stronger and makes the enamel more resistant to the acid attack whenever we eat candy. So fluoride is our friend. The fluoride will help our enamel to be stronger.
Is this fluoride through your dentist or over the counter, for example, in different types of toothpaste?
Yes, there's fluoride in our Chicago public water that's carefully monitored. So in our drinking water, in the water we rinse our mouth with. So that has fluoride in it. And also the toothpaste, any toothpaste that has the American Dental Association seal of approval is good to use. And that usually will, more than 90% of them will have fluoride.
Yeah.
Great question. Thank you.
Are there any more questions for Dr. Sue? All right, thank you so much.
Thank you.
We'll move on to the last speaker for this session. So we have Dr. John Baptiste McClellan. He's an orthopedic surgeon affiliated with Franciscan Health and Little Company of Mary Hospitals, and he is going to speak on bone health. Dr. McClellan?
Okay, well, thank you very much. And let me just say it's an honor to be invited to take part in this. And I wanted you to know that I am a graduate of University of Illinois at Chicago. We used to call it the Abraham Lincoln School of Medicine. So thank you for having me. And so I'm going to talk about some common musculoskeletal issues associated with sickle cell disease. And among these would be avascular necrosis of the femoral head, avascular necrosis of the humeral head, as well as bone infarction, septic arthritis, and osteomyelitis. With avascular necrosis of the femoral head, there are sickle-shaped erythrocytes, which cause vascular occlusion. And that results in ischemia and tissue infarction. Now, the sickle cell patients are living longer due to advances in the treatment of sickle cell, and consequently, their need for treatment of musculoskeletal conditions is increasing. Concerning the hip, osteonecrosis is present in up to 50% of those with sickle cell disease. And this causes collapse of subchondral bone, or the bone directly beneath the articular cartilage, resulting in severe pain and requires surgery. Now, two of the surgical procedures would be core decompression, as well as total hip replacement arthroplasty. And so I wanted to just show an example of an x-ray with
Dr. McLean, so sorry to interrupt you. Do you want to share your slides or no?
Oh, am I not sharing my slides?
No, you're not, sir.
Okay, well, thank you for saying that to me. I guess I got excited. I was seeing my slides, but nobody else was. How about now? Oh, hold on. Almost. What about now?
Not yet.
Not yet?
No.
Okay. Let me try something else. And I apologize, guys. This is not how I envisioned this going. So I'm hitting something that says share screen. Do you see it now?
It hasn't come up on our end. So when you click on share, it would ask you what screen you want to share, and you would see your slide, and then you click on share at the bottom.
Okay.
Yes.
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 Success.
If you want to increase that slide so that we're seeing only that, it seems like we're seeing more of your screen.
Okay.
Perfect. And then perfect. Thank you.
Okay. Well, thank you. I appreciate your help. So this shows a femoral head on the left, and on the right, there is another femoral head, but it has signs of avascular necrosis, which would be the sclerosis in the subchondral bone, as well as at the weight-bearing vector, more or less at the top of the femur. You see this sclerotic lesion. And the sclerosis comes when there is death of the bone followed by repair. And the repair causes the sclerosis because you have bone on a scaffold of dead bone. And so also the stages are beneath that, and they would include stage 1, which is essentially normal, but the patient may have some complaints of pain. In stage 2, you see some thickening of the subchondral bone. Stage 3, there may be even more thickening and a so-called crescent sign, followed by actual compression of the articular surface, which will lead to osteoarthritis. And so one of the procedures in early stages of avascular necrosis would be core decompression. And that's when we take a drill and, well, actually, we start with a guide wire into the femoral head from a lateral position, guided by fluoroscopy. And then I take a drill and hollow out a portion of bone. Now, after that, a good technique would be to take a bone marrow aspirate, place it in the defect, followed by bone graft that I would take a tamp and make it a solid construct. And another one would be a vascularized bone graft as well. Now, this increases vascularity and healing of the femoral head lesion. But it's important that we as orthopedic surgeons do this procedure prior to any collapse of the bone, subchondral bone. And so here is a picture of core decompression. And you can, as you can see, there is essentially a tunnel into the bone. Now, for more severe arthritis with collapse of subchondral bone greater than 2 millimeters, the total hip replacement arthroplasty is a wonderful treatment for this. Even though there may be more complications of the sickle cell disease population than the general population. And also the sickle cell population tends to be younger than the general population. And the perioperative complications would include a higher incidence of infection, excessive blood loss, thromboembolic disease, and longer operating time. And, and we had already talked about the acute chest syndrome by the pulmonologist who spoke so well. And so on the left in this slide is a X-ray of a femoral head that has already undergone avascular necrosis. And you can see that the bone is sclerotic, mixed with a lytic lesion. But more importantly, if you look over the superior weight-bearing aspect of the femoral head, you'll see signs of flattening instead of the typical spherical nature of the femoral head. And it's replaced with a total hip replacement arthroplasty. Now, avascular necrosis can also occur in the humeral head. And I consider these to be analogous to the hip in some ways, not all. And once again, a core decompression can be done for this. There are surgical options for the more advanced avascular necrosis of the humeral head, which would include resurfacing procedures, a hemiarthroplasty, where you essentially just replace the femoral head, but not the glenoid, and then the total shoulder replacement. Now, with the shoulder, you can accept greater deformities before requiring surgery, basically related to the great range of motion of the shoulder joint itself. And so it's kind of small, you're gonna have to squint, but on this one, the arrows show some collapse of the humeral head. And also on the glenoid side, there is a subchondral cyst, indicating that this is osteoarthritis. And now this is a resurfacing prosthesis. Now also, this is a conventional total shoulder replacement, and it's modular. You can see the stem that goes down into the proximal humerus. There is a modular humeral head, and then the glenoid has a polyethylene part. And what I wanted to do is just, I don't know, it's interesting to me. I hope it's interesting to you. But this is on the left is a conventional total shoulder replacement arthroplasty. And you have the spherical humeral head replacement, and then the relatively flat glenoid replacement. Now, on the reverse total shoulder replacement, there is a glenosphere, or the spherical portion is on the glenoid, and the flatter portion is the humeral cap. And this prosthesis is used when one has arthritis of the shoulder plus rotator cuff incompetency. And so it would be a rotator cuff for whatever reason that I was not able to repair, or just do the one step, do the replacement with the reverse total shoulder, and you don't need to repair the rotator cuff. Bone infarction is also a complication with pain related to sickle cell disease. It's caused by sickling of the erythrocytes in the bone marrow. Now, the bone infarctions tend to occur in diaphysis of the long bones, in children, and more metaphyseal in adults. And it can mimic, at least the symptoms can often mimic osteomyelitis. And so advanced imaging is helpful in making the distinction between them. And in some instances, it's necessary for me to do a bone biopsy with, let's say, a Craig needle. I don't have to do an open procedure. I can do that percutaneously and get some tissue to make the distinction. And so here is an X-ray showing bone infarctions of the distal femur and the proximal tibia.
Dr. McClellan, are you there? I'm sorry. It looks like we may have lost Dr. McClellan. Can someone record the questions in the chat, please?
The report, what did you say?
Can someone record the questions in the chat? We'll share them with him. And Dorinda, maybe we should go to the panel discussion if we can't get Dr. McClellan back to finish his talk.
Yes, we want to go ahead and proceed and just If he jumps back in, we might have him ask some questions in the chat.
Okay.
Let's proceed. Let's go to the panel discussion. So Bridget, we're going to bring for, is that Bridget?
Okay. Hi, okay, time for our panel discussion, and we're going to be talking about some sickle cell related health issues and differences in men and women. And on our panel today are, let me get my screen right. Dr. Aisha Hassan and Dr. Brandon Harris. Dr. Aisha Hassan is UIC's own. She is practices in the Department of Obstetrics and Gynecology at UI Health. Dr. Hassan specializes in maternal fetal medicine, and she is particularly interested in caring for women with gestational and gestational diabetes in pregnancy. Her research interests include translational, clinical, and basic science research focusing on pregnancy complications. Dr. Brandon Harris practices the Department of Family Medicine at UI Health, focuses on primary care and urban medicine. Okay, now this summit has to do with treating the whole person. So I'm going to address this question. Either the two of you can answer it. I think I want to start with Brandon. How do you treat this whole person when somebody is your patient? They have sickle cell disease. Beyond looking at sickle cell diseases they have, how do you treat the person, and how do you connect them with who they are as a person beyond being a person with sickle cell? What do you say to them? What do you do for them?
Yeah, thank you for allowing me to be here and to talk something that I think is very important. And working in primary care, it's something we address a lot. I would say, just right off the bat, one of the foundations of primary care, and especially working with patients with chronic medical conditions, is really establishing a relationship. And the number one thing that we think about in primary care is not just how do we treat a disease, but how do we understand who the person is outside of what their labs show, what their diagnoses are. So really understanding everything surrounding the person, where they're from, what is their work and life situation. All of those things are critical to really having a longitudinal relationship. Because a lot of times one visit is not going to be enough to tackle the whole problem, or even to get to the root of the cause, or to get to the root of behavior change, or to do all of the screenings and treatments that we may need to do. So making sure that that person feels comfortable with us is critical.
Yeah, I absolutely agree with Dr. Harris. I think identifying what that person's goals are in life and what stage that they're at in their life is important. For example, if you're seeing a teenager with sickle cell disease, I think the important things are letting them know how their disease is going to affect other aspects of their life. For example, it's not common, but women with sickle cell disease often undergo menarche later on in life. So they might not be having their periods at the same time as their friends are. And sometimes that's very distressing for a young female teenager because they want to be exactly the same as everyone else at every other stage in life. Some of the other issues are women worry about what their fertility is going to be like later if they're not having periods at the same time. Are they allowed to take the same birth control as what their friends are doing? And so kind of understanding where your patient is in terms of what else is going on in their life and how they're seeing themselves in relation to their peers is extremely important.
How do you address your patients to make them comfortable? Because sometimes this
Bridget, you're on
Dr.
mute.
Hassan, I think Bridget is muted. Bridget, would you kindly unmute yourself? You're muted, trying to talk to the doctors. Yeah,
Thank you.
there you go, thanks.
Sometimes when patients see you, they find they may have problems that are difficult to discuss with you. How do you make the environment comfortable enough to encourage the patients to open up to you?
Yeah, I really think that goes back to relationship building, because, you know, like I mentioned before, one visit is usually not enough. Sometimes when you meet a patient, you have an instant connection with them, or you'll have the ability to build a rapport. You have something in common. We're from the same place. Those type of things help break the ice, so to speak. But I found many times, you know, just like how if you're meeting someone for the first time in any other walk of life, you're not going to tell them everything about you right at that moment. Sometimes it takes a visit or two before you actually get to the bottom of it. And that's where making sure that you're establishing that relationship where paramount is respect, understanding, making sure that they know that you care about who they are, not just because they have sickle cell or any other disease, but that you're here to help them in whatever way they need it.
Thank you.
Yeah, I agree. I think the important thing is seeing the whole person and not just someone with sickle cell disease. And often I find it's the provider or us as the doctors who are more uncomfortable to talk about things compared to patients. You know, they've done multiple studies on whether or not patients think it's appropriate for their doctors to ask them about questions about their fertility, or if they're having any problems with urinary incontinence or fecal incontinence, or if they're having sexual dysfunction. And again, patients think that it's appropriate for us to ask. It's often the providers are uncomfortable asking those questions. And so patients are more than willing to have discussions about whatever medical things that we think need to be addressed. We just have to, as providers, be brave enough to have those conversations. And if we don't feel brave enough, to send these patients to the appropriate provider.
I think that's a great point, Dr. Hassan. I find that a lot, especially working with a lot of trainees at UIC with residents and students. If they don't have experience doing it, a lot of times they are a little bit shy asking those more sensitive questions. So I 100% agree. You have to sometimes lead in that respect.
Exactly. Now, we did talk about treating the whole person outside of the disease, but your patients with sickle cell do have sickle cell. So there are some things that are going to affect them that are affecting the rest of the population, but then we might see some differences in how they're affected because they have sickle cell disease. So what kind of tests do you encourage them to have on a regular basis? Dr. Brent Harris, we'll start with you.
Sure. I think it's very important. Again, you know, as a primary care doc, I'm going to say it 1,000 times, relationship with the clinic, relationship with the patient, relationship with the provider. It's such a big part of it because it builds trust. A big part of treating sickle cell preventatively is compliance with therapies. So whether that's you know, making sure they're on their specialized medications, making sure, which is very important, getting their vaccinations. I know vaccines right now are heavily politicized, but for a lot of patients with sickle cell, they need extra vaccinations against certain diseases. They need extra tests, whether it be for children, they might need extra ultrasounds to make sure that their risk of stroke and cardiovascular disease is lower. They need eye exams much more frequently than other adults. Those type of things require trust. And for patients with sickle cell, sometimes those consequences are a lot stronger than you or I, right? If we are individuals who are healthy and don't have these chronic diseases, not getting a vaccine against pneumonia might make us feel bad for a few days. But for someone with sickle cell, not getting your pneumonia vaccine regularly could get you in the hospital, could get you in the hospital with a pain crisis or worse. So those type of things are really important. So I would say vaccines on my part are number one. And then of course the routine screenings with eye exams, ultrasounds as needed, medication adherence.
Yeah, I guess on the women's health side of it, I would, in addition to having your primary healthcare provider, if you have patients or if you are a patient or a woman that is of reproductive age and you're thinking, oh, I may want to be pregnant at some point in the future, sometime in my life, I may or may not, or I don't even know if I want, we always strongly encourage that every single woman have a preconception consultation. And so that's basically a discussion with a high-risk pregnancy doctor just about what are the risks of sickle cell disease in pregnancy and what are the risks of pregnancy on sickle cell disease, because it's a two-way street and they both interact. That being said, the majority of women with sickle cell disease will deliver full term. They will have a healthy baby. So that whole consultation is not to scare you against becoming pregnant. It's kind of for us to learn about your history and for us to kind of also design ways to make sure that you are as healthy as possible before you get pregnant. And that would be, starting extra folic acid to prevent the baby from having problems with the development of the spine, or making sure your nutrition is up to date and make sure that you have enough weight on your bones to support a pregnancy in a healthy way. And also to look through all of your medications to make sure that you're not taking a medication that could be harmful to a new baby in the first 4 weeks of your pregnancy. Again, we would also say that you need to be up to date on your vaccines. And then the other big thing is doing some genetic counseling to talk about if you have a partner and whether that partner has been tested for sickle cell disease or sickle cell trait. Because we can do a lot of that testing before you get pregnant and tell you the risks of whether or not your child would be a carrier, whether your child would have sickle cell disease. And so some of these discussions are easier to have when you're not pregnant. Because once you're pregnant, you're very, very worried about your baby at all times. And so it's easier to have some of those discussions and to make sure that we can get you to the right providers. And if you come to that visit and you're just like, I'm not going to get pregnant, I don't want to get pregnant, we can help you, go down the different avenues of birth control and figure out what are you looking for in your choice of birth control and how can we get you there.
Very good. So another question is, do either of you break the ice with your patient about family planning?
That's all I talk about. But
because
Absolutely.
Because there's a road to get there too. Even before the family planning, there may be some issues in being able to actually produce another human being. So you have issues with priapism in males. You may have painful sex in women that's maybe associated with sickle cell. So how do you talk about those things? And do you prod a little bit or?
Yeah, especially with new patients or patients who we don't have a established relationship with. One thing we try to go through is medical history is of course very important, but social history and family history and understanding what are patients' goals. A lot of times getting an understanding of who lives with them at home, right? What is your living situation? What is your family situation? How many kids do you have? Do you want to have kids? Those are all things that we like to explore with our patients, especially in the context of chronic diseases like sickle cell. It's really important for us to know those things. Just like Dr. Hassan mentioned, planning for pregnancy can be just as important as helping a patient through a healthy pregnancy. So that's something we routinely go through just to make sure that we know someone's goals. If a patient tells me, I don't want to be pregnant for at least the next 5 to 10 years, and they are not taking steps to prevent that, then that's an avenue that we can explore. And sometimes that's something we can address in our clinic. Sometimes that's something we would refer to a specialist like Dr. San. But we have to have the conversation and build that relationship in order to make it happen.
Yeah, and then, in terms of for women, we kind of talk to them about, you know, do you desire to get pregnant? Are you having unprotected sex? If you've been having unprotected sex for a year and haven't become pregnant, then we start exploring avenues of whether or not there are any issues of infertility. Sickle cell disease in general is not associated with an increased risk of female factor infertility. However, menopause does start earlier for these women, just because probably the blood vessels in the ovary get compromised, and maybe there's a potential that hydroxyurea also causes early menopause in women. So it's a discussion to have with them, is if you want to get pregnant and you are not getting pregnant, then what is happening? Because there are avenues of helping to promote pregnancy as well in these women.
So have you seen, just out of curiosity, have you seen people who are torn between hydroxyurea regimen and family planning, planning to have a child? Have you seen people who are choosing one or the other, or do they feel like they have to?
So in terms of risks of hydroxyurea in pregnancy, the animal literature in rats and rabbits, they see a lot of birth defects. And so hydroxyurea in general is classified as something that should not be used in pregnancy. But that comes with a caveat. It's not really well studied. And in the small groups of women who have taken hydroxyurea, the rates of birth defects are not higher than the average population. So it's a discussion that I always have with my sickle cell patients when they first become pregnant. Are you on hydroxyurea? Do you feel like it really helps you prevent having pain crises? And do you want to stop it? Sometimes women will just stop taking the hydroxyurea for the first trimester or the first 20 weeks of their pregnancy. After all of the organs have formed, then they start taking it again. Or sometimes they'll just not take it for the pregnancy and then start taking it again after they deliver. So you have to have a risk versus benefit conversation with your patient.
Thank you. Now, I think after this question, then we can move on to questions from the audience. What about women who are older, who have sickle cell and hormone menopause? What kind of treatments do you advise for people who have sickle cell and are entering menopause, and then even perhaps leading to post menopausal treatment, if any?
Yeah, so in terms of treatments for menopause, the old standard was using hormone replacement therapy, which makes everyone nervous in sickle cell patients, especially because they're already at an increased risk of having blood clots. And so hormone replacement therapy using estrogen may just make that risk that much worse. There are newer and better medications out there to kind of mitigate the risk of some of the adverse effects of menopause, like you can use Effexor or venlafaxine for hot flashes, which helps you avoid using all of that other medication. It's also possible that you can use topical medications if that don't absorb as much. For example, women that are suffering from vaginal dryness can sometimes use the topical hormone replacement therapy rather than taking the pills. So again, every provider needs to have that discussion with their patients of, these are the risks of this medication, these are the benefits of the medication, and how distressing are your symptoms?
Now, last question about menopause, but there are some single hormonal therapies out there. You've got the progesterone, and then you've got estrogen, and then you have the combinations. Is one dangerous without the other? Do you ever use progesterone alone? And is there the risk of depression with the progesterone alone? What do you prefer for patients who have sickle cell specifically?
So for patients with sickle cell, they have found that patients that use progesterone only medications for, for either contraception or for helping with heavy and painful periods, that those patients do have substantial benefits and decreased amount of pain from taking those medications. That being said, the reason that most women stop using progesterone only hormones for either contraception or periods is that you can have more breakthrough bleeding. So I think just priming patients with those expectations that this you will have some underwear that you throw away at the end of the month. That is kind of a guarantee. If you try to take your medication at the same time every single day, that will decrease. But that's one of the side effects. The other issue with progesterone is that there is that increased risk of having depressive symptoms and of weight gain that for some women is extreme. In general, with all of the controlled studies, they found that most women will not gain more than 5 pounds on progesterone. And it's mostly that they feel hungrier, and so they eat more unhealthy options. So the average woman should only gain about 5 pounds, but for some women, that 5 becomes 50 very quickly. And so I think just setting up those expectations is important.
Thank you. Thank you. Okay, I think we are good on our time. We can maybe move on to any audience questions. Have any questions in the queue?
Bridge, I have a question for Dr. Harris. Dr. Harris, I know Dr. Hassan just spoke on the women, but can you also talk about for the men who may be having a situation where maybe, when they have those associated with them having aging under with sickle cell and then getting to a point where they reproductive things happen with them. So can you have a little bit talk on that?
Sure. I think as far as men's reproductive health, I mean, we did briefly talk about priapism, which is related, but I would say as men get older, what's important to remember is that taking care of your overall health is really going to improve your sexual health. And the things, not to get too technical, but the things that really help us age well are maintaining our blood vessels and making sure that our blood vessels are open, we have good blood flow. We know that over time, blood vessel damage is what leads to organs not working correctly. That's one of the reasons why in sickle cell, we are very aggressive in screening for the small blood vessels that lead to the eye, the small blood vessels that lead to the kidney, the heart and the brain. And of course, those that supply our sexual organs are important also. So making sure that your chronic conditions are controlled, making sure that your sickle cell is controlled, having less crises are really going to improve your overall health. So it's really important to look at it as a whole, not just this is one disease and I only need to pay attention to this disease. Sickle cell, as you know, is something that can affect your overall health, your longevity, your mental status, your physical function. So really making sure that you're focusing on that, but keeping an eye on how does that affect other parts of your body. I would also say that sometimes when patients are anemic, they might be comfortable at a hemoglobin level that's lower than what we might consider normal if you don't have sickle cell, but it does have an impact on other areas of your life, right? It could decrease your motivation to be more active. It could affect your mood. Those are things that are secondary effects of having a low hemoglobin count, which we know patients with uncontrolled or sickle cell can notice. So it's important to keep everything in context. So I would say doing the best you can to help maintain your sickle cell and keep it under control is really going to have downstream effects in ways that you might not realize.
Thank you for that, Dr. Harris. Thank you so much.
Do we have any more questions? Well, I'd like to thank you both for coming on today and just educating and enlightening our community. But I would like to say one more thing. You are the optimal doctors for the shy patient. What do you say to the shy patient about being more assertive or better consumer when they get in the doctor's office? Because based upon what we've been talking about here all day long, there are a lot of things to be looking out for when it comes to keeping yourself healthy and averting complications of your disease. So what do you say to that patient about being that shy patient, about speaking up and being a good consumer and being proactive about your disease? Either doctor can answer.
Yeah. So I, you know, a lot of times my first prenatal visit with a high risk patient who's pregnant, I do a lot of talking because I'm telling them about how pregnancy is impacted by their disease and how their disease is impacted by pregnancy, and kind of like lay down a plan of what is recommended in terms of ultrasounds and labs and delivery and all of those things. And then at the end of it, I stop and say, okay, I've been talking for way too long now. What questions do you have? And then usually a lot of times the shy patient will say, nothing, I don't have anything. And I'm like, well, you are going to go home and you're going to talk to your parents or your partner or your neighbor, and they're going to help you think of questions. Write those down. Or, you know, at UIC, we have my chart. Send me a my chart message. You know, when you're not here and you're not in this position of, you know, you're on the spot and have to think of a question right now, go home and think about it. Read my note, because now all of our medical records, you should have access to all of your medical records. You should be able to read your doctor's note. You should be able to see all of your labs. Go look at that and see if you have any questions. And if we haven't addressed anything, you know, I'm going to see you again in a couple weeks. Bring your questions to your next appointment.
Yeah, that's a great approach. I would say what I also try to do for my patients is engage them. And what I found is sometimes patients are afraid to ask questions because, again, they don't know what questions to ask, or they don't want to feel less than if they don't know the answers or if they don't know what the questions are. So they'll just nod their head and say, yes, I understand. I know everything. Thank you very much. But what I try to do is help them learn while we're together. Even though I know that they have so much more time, energy, and opportunity outside the office, it's really an opportunity to say, okay, it's a way for me to understand more about the patient. Okay, where are we? What level do I need to meet you? And do you understand how sickle cell affects your body? Like, do you know what it does technically? What are your red blood cells doing? And I think getting on the same page with that really helps to let them know that I'm not here just to dump a whole bunch of expectations on top of them, but I really want to become a partner in the way that they're able to reach their own health goals. And I think that's really important, that they understand that I am not just here because I'm here because I want to help.
Yes.
Thank you. Very good. I think that's some very good advice. Very good advice. You have to partner with your patient, and the patient has to be a partner in their own health. So if we have no more questions, I think we can move on to our next section.
Thank you, Dr. Harris. Thank you, Dr. Sarah. We appreciate you.
Thank you so much for being here.
Good time. Thank you. We're going to move on to the next slide, which is we're going to go to our second panel. I'm going to bring Miss Rhonda Lay. Are you ready to present our panel discussion on social issues in health?
Yes, ma'am. Good afternoon, everybody. Again, my name is Rhonda, and I'm with Sinai Urban Health Institute. And as we know, there's a lot of us that have a lot of medical concerns, especially with chronic illness. But then there's also social concerns that's associated with those illnesses. So this next panel discussion, we're going to talk about the social issues concerning sickle cell and our health. And I would like to introduce you to first the nutritionist, Truly Gannon from Lindale Christian Health Center. Then our insurance will be Dr. Bell from Sinai Health Systems. Also, we have community health by Demetra Gaines from St. Francis. And the most important also is mental health by Dennis Bourne, which is also from Lindale Christian Health. So I just want to go with the panel. And the first question I want to ask you guys is, tell us a little about your field of expertise and address to us your profession and how you can help us say the dignity of the whole person that's dealing with challenges. So let's start with Truly from nutrition. And then we'll go to Dr. Bell and then Demetra and then Dennis. Thank you.
All right, so I'm Truly Cannon. I work as a dietitian at Christian Health Center, but I also work at Mount Sinai Hospital too, just a PRN dietitian. So I've been working in the community here in London for the past 14 years at Londale Center. And again, what I do and how I can help the sickle cell population. So unfortunately, in my
So Rhonda, can we ask, because I think Julie is kind of pausing. Can you go to the next individual, is it Demetra or either Dr. Bell?
years of working at Lawndale, I have the privilege of counseling a sickle cell patient. But in the research that I've done, I've seen that it's widely underutilized and underdeveloped too.
Okay, since Truly is having a lot of technical issues, can Dr. Bell, are you on and can you answer the same question? Or let's ask you, how do you address or approach the person that may have private issues that they want to discuss with you?
Well,
Dr. Bell.
I'm a primary care internist. I've been doing that for a long time, the Sinai Health System. And currently my role is to do a lot of work with utilization and interfacing with the insurance companies. But if your question was indeed, approaching patients, which I don't do as much of these days, but one has to have an open, non-judgmental attitude of the patient. What is it that you want to talk about, and listen, and then go where the patient leads you.
Okay, thank you. Demetra, can you answer that same question for me?
So what you want to know is how I approach the person?
Yes.
Could you repeat the question, please?
I said, can you address how you approach the person that may have some private issues and want to discuss them?
Sure. Well, first of all, I will start a rapport with that person. Because I work with the people on a regular basis, I feel like you will have a rapport with that person. And if you have a rapport with that person, it will make it easier for you to approach them. And then I will start a conversation, but I'll let them sort of guide the conversation and not just, put my issues out there. I'll let them sort of guide the conversation. I'll listen to them and then interject where need to be, interject. I try not to overtake the conversation by letting them take control of that conversation, and then just, interject where I need to be interjected, and then listen to them, and then give my opinion and things on those different issues and what they're talking about. But I feel like they need to have control of that conversation.
Okay. What about you, Dr. Boyne?
So for me, it matches a lot of what Dr. Hassan was saying in the last panel. I generally just approach things directly, and nine patients out of 10 are there to discuss something private, and so they're open for you to dive right in. And it can sometimes erode trust when you are more cautious with how you approach sensitive topics. There are some patients who will want to sort of test you. They'll bring up something less personal, less private, and see how you respond to it. And then based on that, that's how they establish trust with you. But most of the time, patients are there to see a professional because they want to discuss a sensitive thing, and they're fine if you just address it directly. And as long as you, like Dr. Bell said, if you respond non-judgmentally, then they'll have that comfort discussing it.
Okay, so can you tell me, and for the audience that's listening, what is the difference between a psychiatrist and a psychologist, and what in real time that you allow time for each patient that you see?
Yeah. So a psychiatrist is a medical doctor, and they are trained in both medicine and psychology. And one of the major differences is that a psychiatrist is able to prescribe medication, whereas a psychologist currently is not. A psychologist has a doctorate in philosophy, specializing in either psychology or counseling. So they don't have the medical training or the ability to prescribe medication. But for a number of psychiatrists who do counseling or therapy, there's some overlap. But those are the main differences.
Okay, and so how much time will you give a person that's coming in for the first time for the initial visit and hesitant to even speak about their issues? And how much time do you think that is a good allotment of time? And I'm going to ask each panelist that question. So I'm going to go from you to the next person.
So Lawndale Christian Health Center uses a different model of behavioral health. We use an integrated care model, and within that model, we allot about 30 minutes for each visit, between 15 and 30 minutes. So that's the amount of time the patient would have. If we need to go longer because of the content or because there is the hesitation or difficulty sharing, we can add additional time, but usually there's about 30 minutes allotted.
Okay, and Ms. Demetra, can you please tell me, answer the same question for our audience?
Yes, so before COVID, we were doing a lot of one-on-ones, and I would allow an hour time per person before COVID because it was in person. But now that we're doing everything Zoom and by phone, it's usually like 15 minutes to 30 minutes, depending on the issue of what they have to talk about.
Okay, so can you, just like I asked Dr. Boyne, can you answer a question? What is the difference between you and a social worker?
Sometimes. I'm the title usually. I am a community healthcare worker actually, and I actually work for OSF, but I also work for SCADI, Sickle Cell Association of Illinois, and that's what I do for sickle cell. And so doing community healthcare worker, I have many hats. I am a social worker, I am a nutritionist, I do everything. I'm a parent. I am everything when it comes to sickle cell for the parents of sickle cell. I have many hats with sickle cell. So it involves to be the same. I help people with rent assistance, helping them get housing and showing them how to get housing. I show them how to get Social Security. I've taken people hand to go walk into the Social Security offices to help them get signed up for Social Security for themselves or their children. I've helped them to go get on housing programs and things like that when they need help. I've showed them how to get cheap medical things like RX, when they don't have like medical cards or whatever, to get cheaper medicine and things for themselves. So I wear many hats. So I don't have a social background, but I do all that and some.
Okay, I have a question.
Yes,
there's a question in the chat box that's asking, about nutrition, about social services, and with sickle cell patients. How would you address some of their social needs?
Well, I have a connection. I'm in Peoria, so I have a connection to the food banks as well. So I can call the different food banks if people are like, running behind for the month or whatever. I can say that they're running behind so they can go in and get food. Or if I have a patient that has been hospitalized or something like that, I have such a great rapport with them that I can go in and pick up food for them. And then our pediatric patients have like a snack pack program where when we have patients to come to the pediatric clinic, they get a snack pack bag and it gives them enough food for a couple of days. And currently we're working on an adult clinic, and that's something that we'll carry on to our adult clinic as well. So when they'll come into the clinic, they'll get a snack pack bag and they'll be able to carry those couple, like a week's worth of snacks and things they'll get to take with them home. So we do have a nutritional food kitchen that they can go to and get food and things. Then we have a couple of different food kitchens that they can get food on a daily basis if they need it to. A couple of shelters and places they can go.
Okay, thank you. Ms.
You're welcome.
Truly, are you back with us? Because I have a couple of questions for you.
I think I'm back. Can you hear me?
Yes, I can hear you clearly.
Okay.
There was a question in the chat box for you about nutrition. Earlier, one of the doctors was talking about nutrition is such a valuable component of sickle cell disease. How can you address that for us? And the resources that is needed for a person that has sickle cell?
Are very specialized in is identifying malnutrition. And so, and that is a comorbidity of sickle cell is their needs are very increased because of the increased cell production. And so while it seems like
I think truly we lost you again.
Patients
okay, great.
Are getting adequate nutrition, their bodies need more, and so they need supplementation of some sort. And so what we can do as a nutritionist is I'm still with you?
Yes, just a little bit. You keep breaking up. Maybe if you can get near a window or doorway, that may help us.
Still on? Am I still on?
Yes, you are.
Can you hear me?
Just very little.
All right. I can hear everybody fine. Can you guys hear me?
No, not fine at all. So Dr. Bourne, while she's taking care, there is a question in the chat box for you. And let me get it up. And it says, what's the importance for mental health for a person?
I was talking about malnutrition. And
okay, you're back. Okay.
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 And so, okay. But supplementation. Okay. Okay. I will try to go on my computer.
Okay, for the sake of time, truly, we're gonna have to definitely move on there, and we will have the question and answer box open. And can you please just check that for us and answer any questions that other audience may have? So,
Dr. See if that changes things.
Okay. So we'll come back to you, Truly, and this is a question for Dr. Bourne. and time allow, I'll come back to you. Dr. Bourne, there was an important message put in the chat box, and that question was the importance of mental health with chronically sickle cell disease patients. How do you address the importance of their mental health?
Yeah, there are, I'd say, 3 different areas to kind of focus on for patients with any sort of chronic illness or chronic pain. And one of the major ones is giving them the space and opportunity to mourn the idea of the regular life that they thought that they would have. Dr. San talked about hitting milestones at normal times with menarche or other things like that. And so when you have patients who are experiencing differences from other people or from what they expect, there's a need to mourn that idea, and also to establish and accept and eventually come to enjoy a new normal where they're living life with their chronic illness, and also able to see that they can actually enjoy that life. There's also the focus on pain management. There's something called gate theory in mental health, where you teach a patient using breathing techniques, meditation, diet, exercise, habits to manage the pain, and then also focusing on any behavioral changes that need to be made in terms of having them taking their medication, having them compliant with medication and vaccination, making sure that they're maintaining the appropriate diet and sleep regimens.
Okay, so the second question to that is,
I'm sorry, you muted yourself.
Rhonda, you're muted. Can you unmute yourself? There you go.
did I lose everyone?
We can hear you, Rhonda. We can hear you. Thank you.
I was listening, I'm sorry for the interruption, but I was listening to Dr. Bourne talk about meditation and self-care and what that looks like. And did he leave me?
No, I'm right here.
Okay. So what does that look like to you?
Yeah. So according to the gate theory of pain, there are things that you can do to sort of close the pain gate, and meditation is one of those things, breathing exercises as well. And that meditation can be anything from like focused prayer, that can be guided meditation where you have a video, audio track or something like that leading you through meditation. But it's more using mindfulness and focus on the experience of the body and the senses, and also the imagination to focus on something other than the pain.
Okay, thank you so much, Doctor. And then Dr. Bell left us, so I'm going to lean on you, Demetra, for next question.
Dr. Bell is there.
Oh, he's back? Okay. So Dr. Bell, some of the questions that was asked was supplementary to Medicare and Medicaid, and by adolescents leaving, going into adulthood, what is the probability of them getting their own insurance? What does that look like? Disability benefits, and also it's a multi-question, and durable medical equipment. Dr. Bell?
So I want to make sure, there were a lot of parts to this question. So you're saying the first part was what happens as people age up and get into Medicare? Okay.
Yes.
Okay, well that, once one becomes eligible for Medicare, it does become your primary insurance, and then you would look for various supplementals to cover what Medicare does not. And there's a number of commercial products that are available for them with varying degrees of coverage. And then if people are in a financial predicament and can't afford those, there can be public aid that can be applied for to act as the supplement. There's many insurances that will fill those gaps. It's actually quite complicated, but Medicare itself, the government does have a very nice tool on their website, which would help somebody find what's available depending on your geographic area and what your needs are. And using that tool is the best way to go.
Okay, also, let's talk about pre-authorization for Medicaid or durable medical equipment, because we talked about chest syndrome and some other things and bone and health. And so maybe someone may need durable medical equipment. How do they get pre-authorization, especially for Medicaid?
Reauthorization is crucial because if you get something without getting it pre-authorized, you're going to get the bill. So anybody wants to make sure they do the paperwork correctly. And quite frankly, if somebody's in a hospital setting, working with their social worker or case managerial department is the best way to get the pre-authorization going, because there needs to be a fair amount of medical justification submitted along with the pre-auth. It can be tricky for a person to do on their own. Not impossible, but if you do want to do it on your own, it's best to talk to either the medical supplier who can give you the forms and walk you through the process, or I'll talk again with some social workers, case managers who have some experience in that process. It's a fair amount of bureaucracy. If you do it right, it'll work, but you need to know where the forms are and what to do.
Okay, thank you, Dr. Bell. We have a little bit more time for some questions.
I have a statement about that.
Okay.
I actually have been, I recently met with CVS, the corporation, not the pharmacy CVS. And I was talking with them, and they are claiming that now they can work with our sickle cell population where they can provide all in the whole state, because there's CVSs everywhere. They can provide all the meds for sickle cell patients, and they can monitor all the meds for sickle cell patients and call the sickle cell patients, for example, if they're not picking up their hydroxyurea, they can have people to monitor to say that Kim hasn't picked her hydroxyurea up, and everything can be shipped to them except the narcotics, of course, because narcotics can be shipped to a home. But they are saying that they are going to be able to work with my families here in Peoria, which everywhere, even in Illinois, that they're able to do this, which is game changing for me, because one of the things that I do when I'm talking to my patients, when I know they're not being so compliant, is I ask them, are you taking your medicines? Have you been hydrating? And, those type of things. When is the last time you went to the doctor? And those type of things. So if they're monitoring or have their company monitoring my patients' intake on their medicines and making sure that those medicines are getting to them, because a lot of times I know that struggle of my patients not getting their medicines is because of transportation. If CVS is taking that guesswork out of getting those pills and things to them, that's like a game changer for me. And, it takes several steps out of my job every day. So I'm hoping that what they're saying they're able to do. And I will let the sickle cell world know if this is true. And I will get back to everybody that had me to, be a part of the Zoom to let you guys know that this is something true that they're saying that they're actually going to do. Because I don't know about you guys, but this is a game changer for me and my world of this direction. I don't know about you guys, but I'm super excited about it.
We all are super excited. And I was going to ask you if you had CVS information, could you put it in the chat box for the sake of time and
Right.
stick around for some answers. I mean,
Okay,
some questions.
I don't have it with me, unfortunately, because I'm not in my office. I'm in someone else's office, and I should have brought it with me because it is seriously game changing. But I'll see if I can get it while we're on the phone too. While we're on the computer, I'll see if I can put it in there. All right.
Okay, thank you so much. So we do have just about a few minutes to answer some questions. So either you can unmute yourself or you can put it in the chat box. And right now, I'm looking at the chat box. Let's see.
So this is Dorinda. I have a few questions for Dennis and I'm sorry, Dr. Bourne and Dr. Bell and Demetria. Are you guys willing? I know there's people in the chat posting, and I'm looking at other things come in, but are you guys willing to share your information afterwards, so that maybe some of the individual attendees can maybe reach out to you guys, and if we can get other questions answered on the Zoom? On the summit, can you guys maybe provide information after the summit, so that, you know, like maybe Dr. Bourne, if someone needs to or seeking out mental, you know, health questions or want to see someone, maybe you can provide the information to them. And Demetria, maybe if you have the resources, people can, you know, search out for you and you know, reach out to you and make sure that they can get the resources. And Dr. Bell, the same with you about insurance. So if you guys can share your information in the chat box. I mean, if that's okay, if you're open to sharing, to put that in the text box so people can have your information. If that's something you guys are willing to do, that would be appreciated.
Yeah, I'm absolutely willing to. Also, it's just Dennis. I'm not a doctor.
Oh, I'm sorry.
No problem.
I'm gonna put doctor on you. Apologies.
Thank you. Though.
Yeah, you
Well,
can
yes,
email me
okay.
with questions. Anybody can email me. We'll put my email up. Yeah.
Okay. And if we have any questions, you guys can take yourself off mute and ask questions, or we still have them. We got about a few minutes, and if not, we're going to go to the next portion of the summit. Okay, thank you guys so much for your time. Thank you, Demetria. Thank you, Dennis, and thank you, Dr. Bell. Julie, the same thing goes for you. I know you may be muted, but same thing goes for Julie, the nutritionist. Thank you, guys. So we're going to come to a conclude to our summit, but I'd like to bring Bridget and then also Reverend Henley on to help us do a brief Royal Memorial, since it is National Sickle Cell Awareness Month. September is. We would love to just kind of pay a respect and also acknowledge our warriors who have gone on during the month of September, which is, since it's National Sickle Cell Awareness Month. We want to bring Reverend Denise Henley to talk about UI Health. She's a staff chaplain at the with pastoral care at UI Health, and we also going to have Bridget come on to talk to you a little bit about the Warrior Memorial that we're about to do. Bridget and Dr. Henley.
Who do you want first? Dorinda? Okay, I'm going to start. The term warrior has come into use of late. I'm having reverb.
Go ahead, Bridget.
Okay, the term warrior has come into use of late with regard to sickle cell patients. A lot of patients identify themselves as warriors. And the Free People's Dictionary defines warrior as one who is engaged or experienced in battle, one who is engaged aggressively or energetically in an activity, cause, or conflict. Sickle cell warriors are people engaged in the fight to stay alive, the fight to have the best life that they can have, the fight to be contributors to society, the fight to live life as normally and as productively and engaged as possible. Hence, our recognition of our fallen warriors. And Dr. We will have a prayer by Reverend Henley now.
Reverend Henley, are you? Oh, okay. Reverend Henley, I think you're muted. Can you kindly unmute yourself, please?
think she's saying she can hear us.
You said you don't have a mic?
Reverend Henley is having trouble hearing us, I believe. Or can you try it again, Reverend Henley? See if we can hear you. No, we're not hearing you yet.
No, I'm sorry, we're not able to hear you. No, we can't hear you. We can see you wherever, we can't hear you. Hold on.
Okay, Dr. Sue says she's muted. Can someone unmute her, please?
Okay, so we're gonna give you a few minutes to try to dial in. Yes, we'll give you a few minutes to dial in. Is that okay? Okay.
How about now?
We have you now. Thank you so much. Yeah, we have you. We have you now.
Okay, let me see if I can. How about now?
Yes, we have you. Is it a little noise in the back? We can hear you. Okay, Reverend Henley, you're muted again. We're not sure what's, can you just, we're trying to, hold on. There you go.
How about now?
We have you now, but there's some type of feedback.
Yeah, I'm sorry. I apologize. No mic. So.
Do you have it on your cell phone and on the phone you are?
How about now?
It's a little feedback coming from somewhere.
So I don't have a mic. I'm calling in. So trying to figure out. Let's see if that works.
Well, maybe if you just call in and then take off your the visual, that might have to work.
Okay.
Take the visual off and just speak on the phone. Is that okay?
Let's try to do. Is there a way to unmute the phone? Or
So you're unmuted. What's happening is that we're getting feedback.
Right. I'm unmuting it from.
So I'm thinking if you log off this on the computer and just talk on the phone, that's probably how to work because you're getting a feedback from trying to do both.
I think I got it now. Okay. That's still not it.
No, it's not. Yeah.
My apologies. Is that better?
Yes, it's a little better. Go ahead. Yes.
A little better. Okay. Did you want me a lot better? Did you want me to present and talk a little bit about pastoral care, or did you just want me to do the moment of silence or the? We
would like you to do both. Yes.
Okay. Just I'm looking at time, and I know that we we're limited with time. So I'll go ahead and just tell you a little bit about pastoral care at UI Health. And again, thank you for inviting pastoral care to this forum. On behalf of Reverend Mark Lonez and the Department of Pastoral Care, I say greetings to you. And again, thank you for this opportunity. I am Reverend Denise Henley, one of the staff chaplains here at UI Health. Studies show that it's important to incorporate spirituality into any mode of comprehensive or compassionate care. Just one study published in the International Journal of Indian Psychology found that people who are more spiritual tend to feel that their lives have purpose and meaning and are generally happy than their non-spiritual counterparts. Spirituality defined is simply meaning and purpose. Where does one find meaning and purpose? And that's something that we assess. Inner strength and hope, transcendence in relationships, meaning is there a relationship outside of oneself, such as God or some other being, some other entity that you find where you can connect with, or religion. And religion differs from the whole of spirituality. It is a part of spirituality, but it's not the whole of spirituality. And religion defined as a belief in God or a God. It's the supernatural. It's a social institution involving beliefs and practices based upon conception of the sacred. It's a system of religious beliefs, practices, or rituals. And some of you are familiar with some of those things, such as Christians and Catholics that may desire communion or desire blessings. With COVID and a lot of the other with COVID and a lot of the churches being closed, we have provided additional support to patients, our sickle cell population, as well as others that may desire, as a part of their faith tradition, may desire communion, may desire anointing of oil, may even desire confessions based upon their religious tradition, and utilized our resources to have us to provide those resources, in the absence of their church or parish. So who we are, just a little bit. We are clinically trained. We're undergraduate degrees. We possess undergraduate degrees from an accredited school, a graduate theological or professional degree from an accredited school. We're responsible for obtaining clinical pastoral education, or also known as CPE. It's 4 units if it's done full-time in an institution, and again, full-time work. And it could take a number of years if you are participating part-time. Part of that residency involves you with being a part of the interdisciplinary teams. I know I had a part with training with the residents and attendings, the medical residents and attendings. So you're involved in a very in-depth training. It's 2,000 hours of clinical work experience after the residency. You also must have an endorsement from your faith tradition, your religious group. And you're responsible for meeting 31 demonstrated competencies, professional competencies that relate to pastoral care and ethics and other trainings or other competencies related to chaplaincy. And then as a chaplain, we're responsible for securing 50 CEUs per year. Who we are, we're part of the interdisciplinary team. We're clinically trained to provide support to patients, families, staff, and students. So often we get the question of, do we only provide care to patients? No, we don't. We provide care for patients, families, oftentimes our staff, because of how they engage in patient care, especially with our sickle cell population. They may need times of support themselves. They may need to debrief. They may need to engage in counseling. They may need prayer. And some of them, in fact, I am one of the chaplains that provides prayer for a group of staff members in the sickle cell area. So that is something that the staff participates in. We also do debriefings with the staff, and memorials with the staff, especially again during COVID when it was at its height. We provided memorials for many of our staff members as well as our patients. And again, we also provide support to our students. What do? We provide emotional and spiritual support. That could be assessing for grief and loss, assessing to determine if there's anger and the core of that anger, just kind of exploring that anger. We provide a ministry of presence, sometimes just actively listening, allowing the patient to have that space and that time to be able to process what's going on in their life. Support patients through care planning and decision making. Help patients to process profound spiritual issues such as suffering, loss, guilt, trust, hope, etc., with a non-judgmental presence. So although you see from the credentials that chaplains do possess theological studies as a part of the training, we are non-judgmental in our approach and ecumenical in our approach. We offer prayers, blessings, anointings, baptisms, religious sacraments, and other rituals based upon the faith tradition of that patient or non-faith tradition of that patient. Sometimes patients do not connect to a faith. Sometimes, again, their spirituality is simply nature. It may be energy. So assessing and exploring to see where that patient is and being able to provide the support necessary. We're the liaison with community clergy and faith communities. Sometimes a patient is a part of a faith community, and that patient would like to have that clergy person reach back out to them. We are able to connect with them and set up those type of experiences. We provide end-of-life support, death, grief, and bereavement. We conduct spirituality groups here with our adolescent and our adult psych units. I'm actually one of those responsible for Thursday adult psych group. We do daily orchid rounding, meaning that we try to round on patients that have been in the hospital at least 3 days or more to make sure that every patient, our attempt is to make sure that every patient has a chaplain visit. If there are other opportunities such as referrals, we respond to those referrals. We respond to the patient calls or family referrals to just make certain that we're meeting those patient care requests or those patient needs. We provide a sacred space for patients, family, staff, and students. Again, that's ecumenical or non-denominational. We provide memorials for patients and staff. I participated in the pediatric memorial just last month. We've got a neonatal loss memorial next month. We also, again, have memorials here in-house across the board. We do debriefings following tragic events for interdisciplinary teams, for units, and for students. We provide staff support and availability to our sickle cell, as I mentioned, where sometimes prayers are warranted or just being that listening ear. We sit on committees to support goals of care. And we also we offer advanced directives. We're part of that team. So an advanced directive, of course, is a written statement of a person's wishes regarding medical treatment. Of course, it includes a living will, to ensure that those wishes are carried out. And in the event that person is unable to communicate. The power of attorney the advanced directives are the power of attorney for healthcare, the living will, the IDPH uniform practitioner or post form, which is filled out by the physician and is also different than a DNR or DNI. And then mental health preference declaration. We serve patients regardless of faith, all patients regardless of faith, gender, religion, age, ethnicity, language, or sexual orientation. And our department consists of 9 staff chaplains, part-time and full-time. We have 2 advanced directive specialists. We have a part-time Catholic priest. We have a rather large Catholic population. We have 7 on-call chaplains, and those on-call chaplains cover the staff chaplains, the gaps between the staff chaplains. So they'll cover the night shift, they'll cover the weekends, or they'll cover vacations when staff chaplains are on vacation. We offer 24/7 coverage, 365 days out of the year. So there's always a chaplain available to respond to the request. We respond, we're part of the interdisciplinary team, so we do respond to the codes within the hospital. We have our number 1 emergencies, or in some institutions, it's called a code blue. We respond to the RRTs, the code strokes, and any other codes that are present within the hospital. You'll find a chaplain present there. And we are a training site for clinical pastoral education, otherwise known as CPE. So are there any questions relative to what chaplains do, anything relative to pastoral care? I'm sorry. If not, at this time, we're going to have a moment of silence again, just thinking about the sickle cell patients that we have lost, and those that we support. Just a moment of silence for them. And just as a part of the community, I have a nephew that suffers sickle cell and was just released from the hospital. So I understand the emotional toll that it can take on families, on staff, on the patient. So we'll have a moment of silence at this time. Okay, I'm going to offer a brief prayer. O most gracious Lord, as we conclude the Sickle Cell Summit and have received a wealth of education and sharing of resources, we ask that you would bless every presenter, specialist, provider, and staff that support the sickle cell population. Grant them your compassion as they have extended compassion. Bless them with your grace. Bless every patient and family member with the resources made readily available to bring them hope, healing, and your peace. In your name we pray. Amen.
Thank you, Reverend Henley, for your prayer and for the moment of silence. This does conclude our summit. We're going to bring next Dr. Sue. Thank you, Reverend Henley.
Thank you.
Hello. So we want to really thank all the organizers for this incredible, very rich session that we had. We wish that we could all be in person so we could enjoy our presence more. But thank you so much for everybody joining. We had a chance to hear about the multiple systems and body systems that are involved in sickle cell and about the progress in them for preventive care. And we heard about all the different avenues that somebody could go to in Chicago for help in each of these areas. And so we're very grateful for all the progress. We're very grateful that everybody has been able to pull together and to be able to join, even though it's virtual. And so I want to show appreciation for all the staff, the organizers, the patients, stakeholders, Beverly Chukwudozie, Dorinda Lawrence, Bridget Reynolds. I want to thank Judy Nochek for being the behind the scenes person pulling everything together, and for all the doctors and speakers and other health providers and health professionals. So pray for everybody to have success through the rest of the day. Pray for everybody to have peace and joy, and show love to our neighbors. Blessings on all. Thank you very much.
Thank you, Dr. Sue. That concludes our summit. Thank you, everybody, for joining us and being a part of the summit, participating in the summit. I'm waiting for the slide, I guess. Thank you for your participation. See you next year.